morning, and welcome to today's virtual MMRF Patient Summit brought to you by the Multiple Myeloma Research Foundation. My name is Mary Jerome. I'm the Senior Director of Medical Communications and Education at the MMRF. All of us at the MMRF greatly appreciate you are taking the time today to participate in our virtual Patient Summit, and I'm just going to go over a few housekeeping details with you before we begin. If you need technical support during today's program, please call the technical support line at 1-719-234-7952. The MMRF would like to acknowledge and thank our sponsors, AbbVie, Adaptive Biotechnologies, Amgen, Bristol Myers Squibb, Cure, Genentech, GlaxoSmithKline, Janssen, Karyopharm Therapeutics, Novartis, Oncopeptides, Pfizer, Regeneron, Sanofi, and Takeda for providing educational grants to support this virtual patient summit. It is through their continued support that we are able to provide educational programs to myeloma patients and their caregivers. To submit a question or a comment, type your question in the Q&A box on the left side of your screen and then click send to submit your question. Your question will be addressed during the 2 question and answer sessions of this virtual meeting. I also wanted to let you know that there are several resources available for you to review and download at any time during this virtual meeting. The Resources tab includes the speaker bios and a copy of the slide presentation. The exhibit hall is also a link that you can visit, which includes the MMRF virtual booth and our sponsors' virtual exhibit booths. Each booth contains a number of downloadable resources that we believe you'll find very informative. Feel free to peruse the exhibit hall link at any time during today's virtual meeting. And again, we encourage everyone to submit your questions at any time during this meeting, and they will be addressed during the 2 Q&A sessions that we have in the meeting. Today, I'm joined by several myeloma colleagues. Your host for today's summit is Dr. Laura Finn, who is from Ochsner Health. Also joining us today are Dr. Ambuga Badari from Ochsner Health and Shaji Kumar from the Mayo Clinic in Rochester, Minnesota. In addition, Yolanda Coleman, a patient advocate speaker, will tell us about her patient journey, and we're very appreciative of all the speakers who have joined us on a Saturday. So here is today's agenda. Dr. Finn will give us the welcome to start off, and then we'll give a presentation on the state of myeloma care. Then we'll hear from Dr. Badari, who will talk about relapsed refractory multiple myeloma, and then we'll have about 30 minutes of Q&A with the panel. Then we will have Yolanda give us a presentation on her patient journey. Then Dr. Kumar will give us a presentation on precision medicine and myeloma research. Dr. Finn will finish off with a talk on healthcare disparities in multiple myeloma. We will have another about 30-minute town hall Q&A session with the entire panel, and then I'll make a few closing remarks. So before we begin, I'd like to say a few words about the MMRF Cure Cloud. The MMRF has always been at the forefront of generating and gathering data because multiple myeloma is different in every patient, and we know that we need to collect as much patient data as we can and share that data with researchers to help them find new therapies and a cure for each and every myeloma patient. We always encourage patients to donate their data if they can. In the past, patients have told us that they want to donate their data, but don't know how they can do that. Now, the MMRF has opened the first direct-to-patient registry in multiple myeloma called the Cure Cloud, where patients can choose to donate their own data to our research study. Our goal is to enroll 5,000 patients in this IRB-approved research study, which will allow researchers an unparalleled data set to help use to find cures for multiple myeloma. Through our Cure Cloud portal, patients and their doctors will be able to access both their own data and the data gathered from other patients, which may help the patient and their care teams have better conversations about which therapy might be best for them based on how these therapies may have worked for other patients who are like them. So some of you may be familiar with this study, but for those that are not, you can sign up and sign your consent to participate in the study right on our website. The inclusion criteria for the research study is based on your disease stage and where you live. And if you have any questions about this, please don't hesitate to contact our patient navigators, and I will have that information for you a little later in today's presentation. If you qualify and are eligible for the study, your doctor can sign your blood draw form online. The MMRF will send a technician to your home at a time that's convenient to you, and they will safely draw several tubes of blood. The blood is then shipped to our lab, and the DNA from your myeloma cells, which is in your blood, is analyzed. Additional blood sample is sent to our tissue bank for storage for potential future analysis. At the same time, our partners collect all of your clinical data from all of the doctors you have seen using the information that you provide to us. The myeloma DNA results are sent back to you and to your doctor. You will learn if you have any DNA changes which are actionable, meaning that these changes can be treated using targeted therapies that are currently in clinical trials. And your report may list which clinical trials might be appropriate for you. Not all patients will have these actionable changes. That information is also valuable as you may learn what therapies may not be appropriate for you. Your DNA results and your clinical data are connected to each other in our secure CureCloud database so that a very complete picture of each patient's myeloma is formed, but it is de-identified, so no one will know that it is your information. This is the data that researchers will find so valuable and will be used to speed new therapies to the clinic. You and your doctor will have secure access to a data portal where you can see all of your results once they are collected. You will soon also be able to see the aggregated and de-identified data from other patients who look like you and see what therapies they took and which ones might have worked best for them. And all of this is free of charge to both patients and to their doctors. So I'm going to give a little summary now of where we are with the CureCloud. So at this, and this data, this graph is a little bit outdated, so I need to get another one, obviously. But right now, we have over 800 patients who are fully enrolled and another 200 that are fully qualified, meaning that they are eligible and are beginning the process of having their blood orders signed and samples collected. You can also see at the bottom some demographic information on the study, and there is much more of this type of information available in the CureCloud visualization portal, which just opened earlier this year. You can see a little bump in January of 2021, where we opened the CureCloud study to eligible patients who have smoldering myeloma and who are already enrolled in the PCrowd or PROMISE studies at the Dana-Farber Cancer Institute. If you've been diagnosed with smoldering myeloma and are interested in joining the CureCloud, please call our Patient Navigation Center and our nurses can help you with information on that process. In summary, we'd like to thank the over 800 patients who have already joined, and we encourage all myeloma patients to register and join the CureCloud. Even if you're not eligible right now to join the study, you can still join the CureCloud community, and our patient navigators will be in touch with you periodically to find out how you're doing and if you need any resources from us. If your disease changes and you become eligible for the study, they can then direct you on how to provide your blood sample. The more data we collect in this research study, the closer we can come to finding a cure for each and every myeloma patient, and we appreciate everyone's engagement in this effort. And now I'd like to turn over the program to Dr. Laura Finn from Ochsner Health for the welcome and then the State of Multiple Myeloma Care talk. Laura, it's all yours.
Thank you. So I'm Dr. Laura Finn. I'm reaching out to you today from New Orleans, Louisiana, where I practice at Ochsner Health. Dr. Badari is a partner of mine in our hematology and bone marrow transplant program. I am director of our program, and Dr. Badari is one of our physician leads in the section of multiple myeloma. We're going to talk to you today about multiple topics, which I hope raise awareness of multiple myeloma, normalize possibly some of the treatment symptoms and your cancer journey that may be shared with patients across the country, and let you know that we're on this journey with you. And we take in full consideration both personal cancer care and looking at multiple myeloma as a community of patients with a shared experience. Along those lines, we're going to actually start the presentations today with a discussion of the state of multiple myeloma care. And my intent is to summarize the similarities of multiple myeloma and some of the differences so you can see where you may fall on your experience. Multiple myeloma is something that can be a little bit difficult to understand. It's a blood cancer. That means it's often not something that can be seen externally. It is found through blood test, and it presents in differing ways for everyone. Multiple myeloma is a cancer of your immune system, and a particular part of the immune system, the plasma cells. And plasma cells, when they're changed and they're distorted by multiple myeloma, pose a risk to different parts of the body, primarily bones. Also, that is the housing unit of our bone marrow. It poses a risk to blood because it's a blood cancer and the circulating matter of the blood, and the kidneys filter our blood. So this is how this is all unified together in areas of the body that are at risk: bones, blood, and kidneys. How common is multiple myeloma? It is the second most common cancer of the blood. It is the most common cancer of the blood for our Black patients. There are nearly 35,000 cases diagnosed in 2021, and we have 138,415 patients living with multiple myeloma or in remission of disease in 2021. It represents 1.8% of all new cancers in the United States, and the median age of diagnosis of all genders and ethnicities is 69. So this is a large overview of multiple myeloma. What we see is that there are differences by ethnicity. Myeloma is twice as common and twice as deadly in Black patients. When you see this, you can find your ethnicity and your race on the graph here. We see at all races that the rate of new cancer cases, depending on your gender, is 5 to 8 per 100,000. It is double that, or more than double, in our Black patients. Death rates also show a similar increase by gender. We're going to delve deeper into this disparity in the latter half of our talk today. We wanted to draw attention to it early. Demographic risk factors include older age. We are at risk for certain cancers and disorders as we get older. So the average age of diagnosis was 69. There is a slight gender predominance for male sex. And as we can see, there are differences by race. Our Black patients are twice as likely to have multiple myeloma. There's also an increased incidence in Ashkenazi Jews, patients of Irish descent, and a decreased incidence in our Asian population. There may be inherited factors, and this is still under study. We do see that there is an increased risk of multiple myeloma if you have one first-degree relative with myeloma. First-degree relative would be an immediate relative. That would be a parent, a sibling, or a child. Relatives of multiple myeloma patients have increased incidence of a precursor state of myeloma, also called MGUS, a monoclonal gammopathy of undetermined significance. This is the finding of the same blood tests that show multiple myeloma, but at very low volume, and there is no damage to blood, bones, or kidneys that are defining factors of multiple myeloma. So we do see patterns of multiple myeloma and precursor states in family members that can increase the risk. There are also common symptoms of multiple myeloma, and they can differ by ethnicity of what your presenting signs and symptoms may be. What we're looking for is low blood counts. This would be anemia, particularly a low hemoglobin. The presenting symptom of anemia may be weakness, fatigue, because this is a cancer of the immune system, also an increased risk of infection. Decreased kidney function, which changes in kidney function can largely have no symptoms, but it can also increase the sense of overwhelming fatigue. This would be picked up easily on routine blood tests. And bone damage. Pain is not a very common presenting sign and symptom of multiple myeloma, but it definitely can be present. Bone damage may present as a high calcium level in blood work, or as bone pain if there's actually a fracture of bone. Close to a quarter of patients with newly diagnosed multiple myeloma may not have any symptoms at all. We do see myeloma found by routine blood test, and sometimes while having an evaluation for something completely unrelated. We see this diagnosed sometimes in perioperative assessments, by annual exams, by routine health physicals, actually. There is a difference by these common presenting signs and symptoms of myeloma by ethnicity. We do see that our Black patients are more common to present with the fatigue of kidney dysfunction or anemia. Sometimes a state of fatigue and interesting symptoms of increased urinary frequency, sometimes the jitteriness. Those are signs and symptoms of hypercalcemia, or these findings of a high calcium level, abnormal kidney function, or anemia may be found on routine blood work. What we see less common is actual bone fractures. This is, I'll reiterate, cancer of the immune system of white blood cells. That means there is also an increased risk of infection and hyper-awareness of infection observation and be monitoring vaccines you may need. Types of infections can include bacterial. This probably most commonly be thought of as pneumonia. Bacteremia is sepsis, in a sense, of an infection of the blood. What we see with myeloma, and also an increased risk while on therapy for myeloma of certain drugs, is a risk for viral infections. Varicella Zoster is the scientific name for shingles. Some of the medications for multiple myeloma increase the risk of shingles, as does having myeloma itself. So they're often prescribed protective medications for shingles, or may even be advised to have the dead form of virus for shingles. We advise flu vaccines to prevent influenza and COVID vaccines, all of the vaccines and boosters to prevent the risk of COVID. Preventative strategies, as I'm alluding to, are protective measures. That may include antibiotics for your pneumonia, or if there are severe lowering of your immune system numbers by your blood work, protective antibiotics. Maybe giving growth factors, especially while on multiple myeloma therapy, to boost your immune system to decrease your risk of infection. Age appropriate and situational appropriate vaccines will be recommended. Situational appropriate, I mean, during flu season, recommending the flu vaccine. We're obviously 2 years and a quarter months into the COVID pandemic. COVID vaccines become important. And if you're traveling, also reviewing your vaccines, that you've had what you need, and if there's any needed for the area you're traveling to. And then we call the hygienic precautions, hand washing as often as possible. I should say hand washing before touching your face or eating, and avoiding sick contacts to avoid the risk of infection. Following the proper path helps you obtain the best treatment and results for your specific type of myeloma. I've mentioned common signs and symptoms, but as those watching now and we as physicians are aware that someone's cancer journey is always unique to them. So it's important to identify the right team, experts in cancer centers that have experience in treating multiple myeloma. The right tests have been done not only for your diagnosis, but we have tests now to clarify prognosis and sometimes actually to direct best drugs for treatment, and therefore to lead into the right treatment. And putting all three of these parts together are important for optimal outcomes, and the MMRF is always there to help to identify these steps. The right team, connecting with a multiple myeloma doctor, the Multi-Myeloma Research Foundation can help with resources, identify multiple myeloma treatment teams in your area. And it's always an option to seek a second opinion, and that assistance with reaching out to other multiple myeloma teams can also be provided by the Multiple Myeloma Research Foundation. Mentioned the right test. What may those be? Well, it's more than you may think. It includes blood tests, and blood tests are actually in a more common way that multiple myeloma may be found. Diagnosed or actually found by unintentional testing. This includes a complete blood count. The CBC is the blood test that identifies your blood cells. the white blood cells, and possible presence of anemia. Complete metabolic panel is important to include everything. There's a basic metabolic panel, and this is the complete one. This includes all of your electrolytes, kidney, and liver function. This will be important for identifying hypercalcemia or abnormal kidney disease. Chemistries that can be done separately include testing for calcium and creatinine. Creatinine is your kidney function test. The lactate dehydrogenase and beta-2 microglobulin are inflammatory factors that leading to grading systems and staging systems for multiple myeloma. The serum protein electrophoresis is a test that specifically identifies the myeloma protein in the blood, and the serum free light chain assay identifies a partial myeloma protein. They're used together to diagnose multiple myeloma. All of our blood is filtered through our kidneys. Therefore, these myeloma proteins can also be filtered through the kidneys. That's the importance of these urine tests to see if these cancer proteins can actually be identified in the urine. The bone marrow biopsy is a definitive diagnostic test. It is a test where a needle is put into the soft area of part of the pelvic bone. Myeloma cells, or called plasma cells, can be seen and identified through this test. And a special staining and genetic testing is done to further identify your myeloma specifically by its what we call genetic changes or this genomic sequencing that's mentioned. And then the imaging tests are important to look at your bones. This can be X-rays, MRI, whole body CT, PET scan, mainly looking for areas where the bone may have been destroyed, layman's term, eaten away by myeloma cells. Is called a lytic lesion, or if there's actually a fracture of the bone. The right treatment. All of the tests that were just mentioned lead to the knowledge of providing the right treatment. It's important to know the treatment options that may be available to you, both standard of care and clinical trial options. To discuss the pros and cons of each option with your care team to have a shared decision of the right treatment path for your care. Important for that shared decision is clearly communicate your treatment goal and any concerns to your team. And then always ask if there's a clinical trial that's available that's right for you. Clinical trials have led to the discovery of 14 new drugs in less than 18 years. That's almost a drug per year. See here on this graph, this timeline of drug discoveries. Clinical trials have led to each of these drug discoveries. And through these clinical trials, the outcomes for our patients with multiple myeloma and long-term prognosis has increased every year for the past 10 plus years. These current drugs have improved survival in multiple myeloma. This is a dated graph. We're going to hear from its author today. We see that over decades-long period, we see that survival increased year by year with discovery of new drugs. We superimpose our drug discoveries up to 2015. We can see our prognosis and survival for multiple myeloma is now the highest that it's ever been. We hope to continue that trajectory through ongoing work through clinical trials. This is a general overview. So this is our discussion here is on the state of multiple myeloma. This is a general overview of what the state of myeloma care is at time of initial diagnosis. At some point, almost everyone, myeloma, will likely have a discussion of whether they are a candidate for an autologous stem cell transplant. The care of multiple myeloma usually starts with what we would call an induction therapy regimen. That's the very first treatment regimen you're provided for myeloma, with the goal of getting your myeloma under the best care possible. Secondly, the goal is to consolidate your remission, and that is to keep you in the most controlled state of your myeloma for as long as possible. And the current most common method of that is through stem cell transplant. Now, I have to say, your physicians, a care team may talk to you about stem cell transplant or bone marrow transplant. That's a term that means the same thing. So if you're healthy enough, we would consider a stem cell transplant after 3 to 4 months of your induction regimen. And that usually includes a 3 to 4 drug regimen, call it a triplet or a quadruplet, or even possibly a clinical trial. Your stem cells will be collected and stored. They can be stored for years, actually. And then melphalan is a chemotherapy drug, a very traditional chemotherapy drug. It is usually the medicine used for your transplant before you're given your own stem cells back. That's what autologous stem cell transplant means. Following transplant, the usual standard of care is to be offered maintenance therapy. Two most common maintenance drugs are either Revlimid or lenalidomide, or proteasome inhibitor, that's Velcade, and or supportive care. Well, you should be provided supportive care throughout your cancer journey. If you're not a candidate for stem cell transplant, same medications used for maintenance may be offered, additional treatment regimens, or even clinical trial. Where is the multi-myeloma field going? We're going to hear about this both from Dr. Berdari as he talks about treatment that will be offered should your multi-myeloma relapse, and later this morning from Dr. Kumar as he talks about the next field of myeloma and the next part of our treatment journey. What's being done is additional information gathering to learn how to further use the genetic information about your myeloma, that's genomics, and improving imaging of the bones to earlier identify bone involvement. Learning about higher efficacy using 4-drug regimens. Regimens for multiple myeloma used to be 2 drugs, then standard of care became 3 drugs, and now there are some points of care of myeloma where we're learning that 4-drug regimens provide better outcomes. Precision medicine and targeted therapies in subsets of patients is being studied. We've learned that, for example, if you have a genetic change in your myeloma, and that's a change in what we call chromosome 11 and chromosome 14, certain medications may better target your cancer. We're also learning to use MRD-driven therapy. And MRD stands for minimal residual disease, that try to get to that point, almost an undetectable state, even by genetic testing of your myeloma. Also need to minimize long-term toxicities. I'm sure many of you listening have neuropathy, in addition to other toxicities from myeloma itself and its treatment. Try to minimize those so that not only are you living longer with myeloma, but you have a really great quality of life in your survival. And trying to identify new drug classes and immunotherapies. So to summarize, multiple myeloma is rare. We saw it counts for 1.8% of all cancers, but it's not rare to anyone listening today. It can negatively affect your bones, kidneys, and bone marrow, leading to lowered blood counts and a lower immune system. Therefore, infection prevention is key and requires diligence for observation of infection and protection against it. Survival rates are improving every year because of clinical trials and the discovery of new drugs and new ways to combine the drugs we already have. And the treatment paradigm continues to change as we learn more. For example, possibly going to 3 and 4 drug regimens when that was not the norm previously. It's important to be informed. I think listening to this today and accessing information from the Multi-Myeloma Research Foundation helps that. So you can be empowered to be part of your healthcare team. All right. So I'm going to hand the talk over next to Dr. Berdari, one of my partners at Ochsner Health in New Orleans. Treatment for relapsed refractory disease.
Do we have Dr. Berdari? I think maybe we're quite ahead of schedule, so he might have stepped away from the camera, unfortunately. Laura, I think you just talked too fast. That's the problem. Yeah, actually. So did you want to maybe do a few questions?
I can, definitely.
While we're waiting for Dr. Badari?
Yes, I can.
Okay, great.
So, yeah, because I touched on this, and this is one of the first questions that came in. Is stem cell transplant recommended for multiple myeloma? And what about a bone marrow transplant? Yes, emphatically yes. That we do recommend a bone marrow transplant, which also means stem cell transplant. And the difference is in how the terms, why there's two different terms and why they're interchangeable, is the first types of stem cell transplant are done by collecting actual bone marrow and then filtering it, and that is the main source of your stem cells. Fortunately, that doesn't need to be done in most cases. That there's no surgery involved for most patients having autologous stem cell transplant. Your own stem cells are collected by a special type of blood donation. So everything's done by IV. So it's a way of receiving growth factors, then donating your blood. It is stored for future use and is returned to you by IV drip. There is a special process of going through introduction with a transplant team to see if you're a candidate for a bone marrow transplant. And mainly it's making sure you're healthy, heart and lungs are healthy, for tolerating what is relatively high dose of chemotherapy to receive the stem cells. You may have picked up on the fact that if you're receiving your own stem cells, that doesn't necessarily equal the term of transplant, which usually means an organ from someone else. So another term you may hear from a transplant team, or if you're looking up this process on our nemesis, Dr. Google, is that it may be also called high-dose chemotherapy. And this is melphalan chemotherapy given at high doses to reach really what we consider a cancer stem cell in the bone marrow and suppress it with stem cell rescue, because we're using your own stem cells to help you recover and repopulate actually your whole blood system. It is recommended for almost all patients who are well enough to have a stem cell transplant and don't have, we look at comorbidities that make a transplant too dangerous, but it is considered for every patient with myeloma. All right. Okay. And so we have Dr. Badari back on the line with us. So Dr. Badari, like I said, he's one of my partners that I love to work with here at Ochsner Health in New Orleans. To transition off our talk on the state of care myeloma, we're now going to talk about the care of multiple myeloma when it has returned or has proven resistant to therapy, and that's relapsed refractory multiple myeloma.
Thank you. Can you hear me?
Yes.
Okay,
sound good.
Thanks. Okay. So thank you for the opportunity to present today in front of all of you, and thank you, Dr. Finn, for that excellent overview of the diagnostic and the frontline treatment options for this condition. And like Dr. Finn said, I'm one of the myeloma and blood cancer doctors at Ochsner Health, and I work with Dr. Finn, and I and Dr. Finn also do autologous stem cell transplants for multiple myeloma. So multiple myeloma, as it stands today, is still not considered a curable cancer, and that is changing as we speak. And but as of now, majority of the patients who are diagnosed with multiple myeloma at some point have their multiple myeloma return, and that is called as the relapsed multiple myeloma. And a small percentage of the patients who have multiple myeloma also have their initial cancer or the initial multiple myeloma that is resistant to the treatment, and that is called as refractory multiple myeloma, despite the standard of care of chemotherapy and other frontline treatment options. And there are also other definitions that you might have heard or you might see it used. There is a term called progression, which might not always be relapse. There is also an entity called biochemical relapse or biochemical progression, wherein that there is a slight increase in the commonly used parameters in the blood called M protein or SPEP, values that you encounter, but that does not always warrant a change in the treatment. It might just need to be observed closely. And again, when we use say a line of therapy in multiple myeloma, usually the frontline therapy includes the initial chemotherapy that you get, and that usually also includes the stem cell that's considered the first line of treatment, and also the consolidation chemotherapy or the maintenance that comes often after the stem cell transplant. So all of that is considered the front line or the first line of therapy. And subsequently, post consolidation or post maintenance, we go to the next line of treatment. And now we have multiple options if and when you do have that relapsed disease. So again, there are lots of options in the last 5 years that Dr. Finn alluded to. Just in the last 5 years, there have been about 6 to 8 new therapeutic options for relapsed multiple myeloma. So this table, this slide gives the common class of drugs that are used in multiple myeloma. And again, some of these drugs are used in frontline. Some of them are used in the later lines as well in different combinations or individually. So they mainly, there are 5 or 6 different class of drugs. The first is called IMiDs or immunomodulator drugs. And 3 drugs that are available are thalidomide, which is not commonly used in the US, but used elsewhere in the world, including a lot of European countries. Revlimid, which is the commonly used drug here in the US, both in the front line and later lines. Pomalyst, which is mostly used in the second or later lines of treatment. Then we have the proteasomal inhibitors, also called PIs, and commonly these are the drugs that are used in the frontline setting as well as the later lines. And Velcade or bortezomib is the commonly used frontline proteasomal inhibitor, which is an extremely important drug, especially when the multiple myeloma involves the kidneys, because it is very safe in that setting and is also very effective in clearing the multiple myeloma that involves the kidneys. Kyprolis or carfilzomib is another drug that is also used sometimes in the front line, sometimes in the later lines. And Inlara or ixazomib is an oral form of proteasomal inhibitor that has been approved both in the front line and later lines. Chemotherapy use has come down of late, but it's still used in certain settings when you need very fast responses or in the setting of the refractory multiple myeloma. And a number of drugs are used and they're still used, including cyclophosphamide, adriamycin, doxil, bendamustine, and melphalan. That is commonly used in the non-transplant option when your transplant is not an option, or for the high-dose chemotherapy before the transplant. Steroids, both dexamethasone or decadron and prednisone, are mainstay of multiple myeloma, both in the frontline and relapse setting. And there are newer drugs, including selinexor or venetoclax, and monoclonal antibodies, including daratumumab or Darzalex, isatuximab, both of which target a protein called CD38 that are expressed on multiple myeloma cells. Another drug called elotuzumab, which targets a protein called SLAMS-F, and Blenrep, which is an antibody drug conjugate, which targets the antigen called BCMA. And now we also have 2 new class of treatments called the Cardi, two Cardi therapies that also target the BCMA antigen. One is called Abecma, and the other is called Carvykti, which was just recently approved. So we have a whole multiple options. The bigger question is, how do we choose the therapy, and how do we go about choosing the therapy for you, as in individualizing the therapy for every patient whose multiple myeloma may be unique. So there we look at various aspects, and including what was the prior therapy that has been used and how well did it work, how long was the response last, and the most importantly, did the myeloma progress on active therapy, which just means a marker of resistance to that class of drug or drugs, and so which most likely should not be used in the next line, and whether the myeloma had high-risk features with FISH or other markers, including cytogenetics or gene expression profiling, which can direct the next class of drug or drugs that we use. And also the patient factors are extremely important, including how old the patient is and how frail the patient is, what are the other medical issues. Do you have diabetes? Do you have history of blood clots? How do you have peripheral neuropathy, and how bad is the neuropathy? And whether you prefer getting an injection or a shot versus an oral pill, or an IV infusion. So those are some of the personal patient-specific factors that we consider in deciding the treatments. And coming to the disease-related aspects, the duration of response to the initial therapy is possibly very important. The longer the duration from the frontline therapy, it's possible that we can reuse one or more of the same drugs that we used initially, as opposed to having a shorter duration of response, let's say less than 12 months from the initial treatment, possibly indicates resistance to that line of therapy, and possibly we should consider what we call as a class switch to a different class of therapy. And also the FISH at relapse is also possibly important, and sometimes the multiple myeloma, which might be less aggressive initially, possibly can acquire more aggressive characteristics at relapse, and possibly that would also warrant some different line of therapy, especially now with the presence of the 1114 that Dr. Finn mentioned. The translocation of 1114 opens up more targeted therapy as well in multiple myeloma with Venetoclax. So the prior treatment-related factors like for how long have you been on the maintenance, especially with Revlimid or lenalidomide, factors in whether we should be using the Revlimid or lenalidomide in the second or third line therapy, because the longer the duration of exposure to Revlimid or lenalidomide or IMID means that you might be resistant to that class of drug and possibly would warrant a different drug or drugs in the second line or third line setting. How did you tolerate the treatment? If you have been exposed to a lot of Velcade and you developed neuropathy from that, and it might not be possible to use more of the Velcade or even carfilzomib, which is Kyprolis, because they have the same neuropathy effects, which is very a quality of life issue for a lot of you and a lot of myeloma patients. Mode of administration is also important, and there are some oral-only regimens that are available now, which would save the hassle of coming to the cancer center for multiple times in a week or month. Prior transplant also figures in the decision making. If you have had a stem cell transplant, have had a reasonable benefit from that, say for at least 2 to 3 years, you can also be considered for a second stem cell transplant. But if the prior stem cell transplant and benefit has been, say, less than 2 years, that benefit for a second transplant is questionable and possibly not used at all. And again, overall general health and age all also figure into these treatment decisions, but mostly in conjunction with all the other factors we discussed. Again, for the first relapse, that is the treatment after the initial chemotherapy with or without stem cell transplant and further maintenance therapy, the options would include another proteasomal inhibitor. Again, if you used Velcade initially, we can possibly switch over to Kyprolis. If we use Revlimid in the frontline setting, we can possibly use Pomalyst in the second line setting. And we commonly use the antibody-based therapy, which would be daratumumab or isatuximab, if there is if it's not been used in the frontline setting. That would be a usual combination in the second line setting. And if the third, that is a second relapse, that is in the third line setting or more, again, we try to use options that are not used in the previous lines and are not being used up. Again, if you are refractory to both Velcade and Revlimid, which we call as so we tend not to use the same drugs. Of course, we use the daratumumab, which is The options here are including daratumumab, Kyprolis with steroid, isatuximab, which is another CD38 antibody with Kyprolis and Decadron, daratumumab with Pomalyst, which is similar to Revlimid and Decadron, elotuzumab, which is another antibody with Pomalyst, and so forth. So those are the combinations. So if you are refractory to a Revlimid but sensitive to the proteasomal inhibitor, that is Velcade or similar drugs, these are also the options that can be used. Or in addition, we can also use the Velcade again, a DVD, which is daratumumab Velcade, and selinexor, which is a novel drug, which is a pill that works very differently from these drugs, can be combined with Velcade, or Venetoclax Velcade combinations for those patients who have this translocation of 11-14, which is seen about up to 15 to 20% of relapsed myeloma patients. So the more challenging would be what we call as the triple class refractory. That means you are refractory to the standard drugs, that is Revlimid or Pomalyst, and also the Velcade or Kyprolis. Then we cannot get any more benefit from mixing and matching these drugs. And for these patients, we can again use selinexor combination, which if it has not been used in the earlier lines, we can use belamaf, which is again an antibody drug conjugate that targets the BCMA antigen on the plasma cells. And we have the CAR-T, two CAR-T options, the ide-cel and cilta-cel, that have been recently approved. And of course, the clinical trials are always on the horizon and should always be considered for clinical trials, where MMRF can certainly be very helpful in guiding towards the available clinical trials. So there are, again, options, a lot of new options available. So these are the, again, we talked about briefly. So the standard drugs, the proteasomal inhibitors, there are 3 proteasomal inhibitors, which is again Velcade or bortezomib, which can be used as IV or subcutaneous form. And again, it has been approved both frontline and relapse setting. We have Kyprolis, which is carfilzomib, which is again approved only for IV. It is an infusion and it's given once a week. And it has been approved again for the frontline and for the relapsed refractory myeloma as a single agent, or with a doublet with a steroid, or as a triplet with the Revlimid or Darzalex with steroid. And more we are using the triplet therapy in the relapsed and refractory setting as well, because there is clear evidence that using a triplet combination, that is 3 drugs in the relapsed setting, is beneficial over 2 drug combinations. So then we have the Ninlaro. We have again a pill, which is also a form of proteasomal inhibitor, and it is used as a triplet along with Revlimid and Decadron. So the IMiDs, that is the available immunomodulatory therapies, are Revlimid, which are once daily pill that is again known as which is approved for the frontline as well as the relapse setting, and Pomalyst, again it is once daily pill for that is given as in a 14-day or a 21-day regimen for both relapse refractory myeloma in combination with Decadron or with other drugs. Then we have the monoclonal antibodies, which are again target either the CD38 or the SLAMF protein and on the plasma cells. And we have 2 CD38 antibodies, which is one is Darzalex and the other is isatuximab. The Darzalex has now been approved also in some frontline settings, so it is given as IV or a subcutaneous format. Initially, it was approved as IV. Now it is more conveniently can be given as under the skin, which is very hassle-free way of getting the drug, just like the Velcade. And then for the relapsed refractory myeloma, it is approved as a single agent or as a triplet with Revlimid or Velcade or Kyprolis or Pomalyst along with a steroid. So it can be used in with multiple other partner drugs. For isatuximab, that has not been approved in the frontline setting, and it is an IV infusion. It is given as weekly for the first 4 weeks and then every other week. And it has been approved in the relapsed refractory setting as a triplet with the Pomalyst or Kyprolis and with the steroid. Implicity or elotuzumab, again, that is a different form of monoclonal antibody. And it has been approved for the relapsed refractory setting as a triplet with the Revlimid or the Pomalyst with the steroid. And it is given again weekly for the first 8 weeks and then every 2 weeks or if it is with Pomalyst, it's given every 4 weeks. So all these drugs and in combination, they can have adverse effects, but overall they are very well tolerated, even when combined with the other drugs we talked about. If again we briefly mentioned selinexor, which is called Expovio, which is it works on a different mechanism by inhibiting the exportin transport in the cancer cells, and it is given as a weekly pill, which is very convenient, and it is approved for the relapsed refractory myeloma as a triplet with Velcade and Decadron, and it is effective in fourth line and beyond for patients who have progressed in those setting. So this is the more challenging aspect where you are refractory to 3 lines, which is triple class refractory, and often we call as quad refractory, which if we include the daratumumab as well. So then we have fewer options after you exhausted all these the standard options. And this includes patients who received treatment and did not respond satisfactorily, or who have progressed while on treatment with the 3 main classes, which is the proteasome inhibitor, IMiD, and the anti-CD38 monoclonal antibodies we talked about. So for the triple class refractory, now we have option with a selinexor combination, selinexor with IMiD or with proteasome inhibitor. We have the antibody drug conjugate, which is Blenrep, which is given once a weekly as an IV infusion. Or we have the 2 Cardi drugs that are very novel and which are available in selected centers, but also very effective form of cell therapy that is been approved for the 4th line and beyond at this time. So belantamab mafodotin, which was approved about 2 years back. It is a form of antibody drug conjugate, wherein what they do, what is done is an active cytotoxic drug is combined with an antibody that is directed against the BCMA that is present on almost all plasma cells or myeloma cells. So it targets and binds to the BCMA receptor on these plasma cells, and it is internalized inside the cancer cell, and it is achieved cell kill by multiple mechanisms, including antibody-mediated toxicity and by NK cell induced killing of the cancer cells. It is a very effective form of treatment for multiply relapsed multiple myeloma. It does come with some eye toxicity, which can be managed fairly easily when we coordinate with the ophthalmology clinic before each treatment. Cardi Thistle therapy is a form of cell therapy which has been initially approved for some types of lymphomas a few years back, and it has been now approved for some types of acute leukemias, and now most recently for multiple myelomas as well. So again, the currently approved Cardi therapies for multiple myeloma also target the B cell maturation antigen that is present on all myeloma cells. And the mechanism here is that it is a process, so it is not readily administered in this clinic. So we have to collect your cells in the clinic or in the infusion center, and that is processed in a facility that is maybe located in other parts of the country, and they modify your T cells or the lymphocytes to target back your myeloma cells, and that is infused to your body after a round of chemotherapy, and that has been found to be very effective in achieving the destruction of the myeloma cells, and very successful so far. So what about second stem cell transplant? Again, like we mentioned, it depends on many factors, including how long have you had the benefit after a first stem cell transplant. If you have had at least anywhere between 2 to 3 years of benefit after the first some enough cells that are stored, or if your health overall permits for a second stem cell collection, there is benefit of going to a second stem cell transplant, and usually the response is not as robust as with the first stem cell transplant, but it can still be very useful in some selected patients. And like you see in this graph, so we do have at 4 years compared to cytoxan or cyclophosphamide chemotherapy, the patients who got a second stem cell transplant still did well in terms of how their disease myeloma not progressing. So what is coming? And again, like you see, a lot of newer options. Again, Dr. Shaji Kumar will talk about the precision medicine in multiple myeloma, and a lot of these drugs are based on finding the novel targets on the plasma cells or in your blood that can be used to target these drugs, and a different mechanism of action that have not been considered historically in myeloma. Those are all being considered. And there are newer antibodies, antibody drug conjugates, a newer class of drugs called BiTEs or bispecific T-cell engagers, different types of CAR-T that is targeting other antigens from BCMA, and checkpoint inhibitors commonly called as immunotherapy that are being used in other cancers. They're all being studied either singly or in combination, and it points to a very exciting next few years. To summarize, most patients with multiple myeloma will have their disease relapse. Good news is that there are multiple newer treatment options and to keep your disease in remission for an extended period of time. And often patients these days get anywhere between 4 to 6 lines of treatments or even more with so many different options available. And it has become, multiple myeloma has become almost like a chronic disease rather than an acute condition. It is so it is we are here for a long run with a lot of available options, and we talked about all the available newer drugs and the pipeline that are being on the horizon. And there are always considerations for the toxicity, quality of life, and other considerations when we talk about newer therapies, but overall, the available options have been good and can be used safely with all the precautions that we normally take. And there are again newer clinical trials that are in the works, and which is definitely looking very exciting. Thank you.
Thank you, Dr. Bhandari, for that great overview of relapsed refractory myeloma and its considerations and treatment. We're going to move into now our first of our 2 town hall question and answer sessions. And actually, I'm going to start off, since we're just finishing the relapsed refractory section, some questions that pertain to that. And as you talked about CAR T-cell therapy, one of the first questions that came in is a question of why Abecma, BB2121 is right now offered only in the relapsed refractory state, and you think it would move to an earlier line of therapy?
Yes, right now it is being studied again in the third and fourth line setting and beyond. So it is possible it will be moving lines, but again, with all the available therapy, it is I don't think that is going to happen anytime soon. That said, with the lymphoma CAR T therapy, it was initially approved also in the third line and beyond. We see that moving to the second line, so it is possible in the next few years that the CAR T, either this one or a different CAR T, might be approved at an earlier line.
Okay. And another patient question regarding CAR T, does CAR T therapy, because it targets BCMA, have an effect on normal plasma cells?
Yes, it does. So BCMA is universally expressed in all plasma cells, both cancerous and normal plasma cells. So there is the consequence of that. There is a paresis of the plasma cell activity, that is normal plasma cells which protect against infections, that activity will be suppressed for an extended period of time. So antibiotic treatment and possibly IVIG, which increases the immunoglobulin levels in your blood, which need to be used for a period of time because the activity is suppressed of the normal plasma cells. Yes, it does.
Okay. And I'll take a question because I think it falls into the first talk about an overall summary of myeloma. I have a question of kind of what level of M protein would require treatment. And I think that becomes a question of what level of M protein is a diagnosis of multiple myeloma. It can be almost any level. I say that because if there is already damage present and that damage is proven to be multiple myeloma to your blood, that means whatever level of myeloma protein is present is causing anemia or causing renal failure or damaging bones. Any level of an M protein could be a diagnosis of multiple myeloma. Now, it would be 3 grams on its own, but again, it also requires all the other blood tests we talked about in the beginning, blood test, urine test, a bone marrow biopsy, and bone imaging to really not only follow that M protein number, but see how that myeloma protein is affecting the overall body. All right. I have also a question about relapsed refractory multiple myeloma. Ninlaro, is it administered by itself or in combination with steroids?
So Ninlaro has been approved both as a drug by itself in the maintenance setting and in combination with steroids, which is usually dexamethasone, as a relapse in the setting of the relapsed refractory multiple myeloma. But if it's been used in the maintenance setting, it can be used as a single agent.
Okay. And a question also, a lot of questions about the BCMA-directed therapies. If someone has been on Blenrep, are they also a candidate for CAR T-cell therapy since they both target BCMA?
So we do not know the answer to that because there is obviously if the Blenrep has targeted the BCMA. What amount of BCMA is needed for the subsequent CAR T to be effective is not clear at this time. There are patients who have received Blenrep and have proceeded to the CAR T therapy with varying degrees of success, but the answer to that is not entirely clear at this time.
Okay. And I'm going to take one of the questions because also is about our first talk about the state of affair of myeloma and the fact that I mentioned growth factors as a protective measure. And we have a question of what those are. So what can happen with myeloma itself as it the myeloma cells can fill up the bone marrow and its impact on the immune system may not only affect plasma cells, but may actually decrease levels of other normal immune cells. The most important immune cell is the neutrophil that protects us against infection. That can happen, a decrease in your neutrophils can happen by myeloma itself, and probably more commonly, sometimes as a side effect of myeloma treatments, and that's a state called neutropenia. So we have growth factors, they are neutrophil growth factors that can be given by injections that will hopefully boost that level of neutropenia, or boost that neutrophil count to a count of 1 or higher, and that provides a better protection against infection. Okay. A question, probably for the group. A patient with smoldering multiple myeloma, are there treatment options recommended at this time for smoldering myeloma? So that probably goes into, we know our talk right now is about multiple myeloma. We can answer this question because we mentioned MGUS as a precursor state. Smoldering myeloma is also a precursor state to multiple myeloma. And right now there's actually clinical trials designed to determine whether medications such as lenalidomide, which is also goes by Revlimid, either alone or in combination with daratumumab, may be a treatment option for smoldering myeloma, especially if we use some of the same testing measures that we use for myeloma to define a high-risk disease to try to prevent the development of multimyeloma. So there are some considerations for treatment and also clinical trial options for smoldering multiple myeloma. Okay, I'm going to go through a list here. Okay. Okay, this is a question that I imagine Dr. Kumar may actually approach in his targeted therapy talk. What is the consideration of a P53 mutation in the treatment of multiple myeloma?
Yeah, thank you, Dr. Finn. So I think
You're welcome.
the P53 deletion 17p, or the loss of the short arm of the chromosome 17, is typically associated with a poor outcome in patients with both newly diagnosed and relapsed multiple myeloma. So in the presence of that, again, high-risk multiple myeloma, we need to treat them with the multi-drug combinations, as was been mentioned in the previous talks, preferably with those 4 drug combinations, including monoclonal antibodies, trying to get them to a deep response and then maintaining that response using 2 drugs used in combination. Now, specifically the P53, there are some studies ongoing that are looking at ways to make the remaining P53 gene more active, so to speak. They're targeted therapies. We had done one of those studies in the Multiple Myeloma Research Consortium, but still a lot of work that still needs to be done in terms of developing targeted approaches for that particular abnormality, outside of just trying to treat them with the most intensive therapies that we have.
Mm-hmm. Selinexor, as a comment, seems to be a very therapy. Do we see its use moving into earlier treatment for relapsed refractory multiple myeloma?
There are trials ongoing, but as of now, it is the data are not yet there to use it in the earlier lines.
Okay. All right. I'll answer a question here, and it's about I've had stem cell transplants. And when do I need to speak to my treatment team about vaccine therapy? Because this may be a little bit in flux in our COVID era. Most cancer centers, including ours, are likely to recommend restarting vaccines, which for this point of discussion, talking about vaccines after bone marrow transplant, don't just include the vaccines we talked about for flu, for shingles, and for COVID, but it includes all of your vaccines, everything we tend to receive as children for protection. We have to wait after bone marrow transplant for enough of the cells of our immune system, which are the lymphocytes. They need to develop enough after transplant to be able to start accepting the vaccine and creating your vaccine immunity. That can, for such a large volume of vaccines, like our childhood vaccines, that tends to take about 6 months after bone marrow transplant. We are offering at our institution flu vaccine and COVID vaccine, since you're not receiving. So if you had your transplant, just to warn you, when you go for your routine post-transplant vaccines, it's like 5 shots per visit. It includes like measles, mumps, rubella, pertussis. So if your transplant team hasn't warned you, at least now someone has, but receiving things like flu vaccine and COVID vaccine, we recommend, especially in infection time, like flu season, and of course we've been in COVID season here for a few years, getting those vaccines as early as 3 months after transplant. And you do have enough lymphocyte development to get a few vaccines that early after transplant. Okay. So a question now, because we mentioned quality of life and neuropathy, and I will answer, and maybe Dr. Bhandari and Kumar can answer if you have other experiences. But one question, does anyone with myeloma not develop neuropathy? So I say it's a common side effect. So I think we expect to see it in most of our myeloma patients, but there are a handful, at least I have in my clinic, that haven't developed neuropathy. And the second part of that question, what are effective therapies for neuropathy? So things are often offered that include medications as not necessarily anything that reverses the neuropathy and nerve damage itself, but to alleviate hopefully some of the symptoms of that. Specific medications for neuropathy include medications called gabapentin to try to relieve that nerve type of pain. There are also some types of antidepressants that may be prescribed at night because they also have a sedative side effect that can be effective for neuropathy. And we offer an integrative medicine department that also performs acupuncture that we've seen patients experience benefit from. But I have to admit, as a cancer physician and also a bone marrow transplant physician, I find neuropathy one of the most difficult side effects of myeloma and its therapies to treat. And I don't know if Dr. Bhandari or Dr. Kumar, you have any other experiences with neuropathy and its treatment?
I think the key thing is, again, trying to prevent it from happening in the first place. And thankfully, the medications like Velcade that has been associated with is less likely to cause it when we give it subcutaneously and give it once weekly. But I think the important message, I think, for everyone is if you start noticing any symptoms, report that right away. Don't disregard it. The best way to prevent it from getting worse is to stop that particular drug or decrease the dose of it.
Thank you.
And often it's also about managing the other comorbid conditions. For example, if you have a poorly controlled diabetes, that can add on to the neuropathy, and which is that much more difficult to control. So what can be controlled must be controlled in an optimal manner. So.
Thank you. We have a transplant question, which I can answer. Can stem cells be harvested more than once? The answer is yes. So there are a lot of maneuvers that are done by your transplant team, sometimes upfront, to prevent the need for harvesting your cells more than once. And I'm going to do a technical clarification that when I say harvest, I mean the most common way of collecting stem cells, which is by the special type of blood donation and collection. Is if you, after this talk or during this talk, if you actually Google harvest, you're going to see that's an operation in the OR, which is very rarely done for a bone marrow transplant. So when we talk about harvest, we're talking about the normal type of blood donation for a stem cell transplant. That can be done more than once. Many transplant centers will attempt to collect enough stem cells for 2 transplants. The amount of cells that are donated can actually be split and cells kept in the stem cell lab freezers for use in the future. If that is not done or enough cells cannot be collected for 2 transplants up front, yes, there are medications now that allow us to be able to collect cells after many types of treatment and sometimes many years of treatment for a second transplant. And on very rare occasions, if a second harvest is not successful, there's also ability to actually do the traditional bone marrow harvest, or if it's a bone marrow transplant is absolutely considered needed as a repeat procedure in the future. All right. Okay. I'll ask this question to Dr. Bhandari because it's a question about steroids. And does it always have to be dexamethasone in combination with treatment?
No, it does not. Traditionally, it has been dexamethasone, but there are a lot of studies and regimens which include prednisone. But the trials that, especially these recent trials, have always included dexamethasone, which is supposedly the more effective steroid in myeloma. So.
Okay. As I talked about transplant, more transplant questions came in. So let me answer some of those. One question, how many cells are needed for a successful bone marrow transplant? It's going to sound like a lot, but it's actually a very small volume. We recommend having at least 2 million cells for a stem cell transplant. That's usually easily donated at the time of your stem cell collection. And I think because I mentioned that stem cells can be stored and kept, how long can they be stored for? And it can be stored for years, actually decades, in a stem cell lab that maintains the quality of their freezers. And I can offer anecdotally that the oldest stem cells I used for a second transplant were almost 30 years old, and they were still viable after storage. So it kind of includes technique for storage. Okay. All right. So a question for Dr. Bidari about your relapse refractory discussion. If a patient receives a 4-drug regimen, the DARA plus Velcade, Revlimid, and dexamethasone, what are treatment options in relapse refractory state?
So that's increasingly becoming a question in front of us. So again, that depends on how long you had the response and how after that initial treatment. So if you have had a good response, which if we include transplant as part of that initial treatment, and you had a sustained response which lasting, say, more than 24 months or more, we can re-challenge at relapse with one or more of the original drugs. And usually, if we look at the algorithms now, if you use a triple drug combination in the second line or the relapse setting, it typically includes using elotuzumab, which is the other monoclonal antibody, because we do not want typically reuse the daratumumab that has been used for an extended period of time, especially if that regimen also included daratumumab as a maintenance option. So it would be typically elotuzumab, say pomalidomide and decadron, dexamethasone maybe in the next line setting, and or elotuzumab with the proteasomal inhibitor and dexamethasone. And again, depends on whether if you are a candidate for another transplant, again, that has to be factored in for the next line of treatment as well.
Thank you. I have a question for Dr. Kumar, because it's going to relate to your talk, but I'm also trying not to reveal too much of your talk early. It is a question of how useful is FISH analysis and other DNA testing, and how does it guide treatment?
The FISH analysis is definitely part of the routine clinical workup, because it will help us identify the high-risk cytogenetic abnormalities like the 17p deletion we just talked about, as well as a variety of translocations and other chromosome 1 abnormalities. So the presence of this would indicate high-risk multiple myeloma, which then would be treated more aggressively than we might treat a standard risk multiple myeloma with the 2-drug maintenance and use for a long period of time. So that test will change how we approach the disease over and above the prognosis determination. The DNA testing, and we'll talk about that in more in-depth on my talk later on, allows us to identify mutations that involve specific genes, and we know there's about a dozen of them that are commonly seen. That is an area of active investigation to see if in the presence of specific mutations, we can use specific drugs. Outside of a clinical trial setting, most of the DNA-based analysis currently don't alter therapy. Hopefully, as we learn more about it in future, that will likely become part of the routine care.
Mm-hmm. Thank you. I have a question here, which I may answer because it's probably more on frontline myeloma therapy. If someone has neuropathy, what is the recommendation for maintenance therapy? And so I'll answer that we actually have 2 more commonly used medications for maintenance therapy. One is Revlimid, and the other is Velcade. And as Dr. Kumar discussed earlier, use of Velcade by giving sub-Q injections instead of IV has decreased the incidence of neuropathy, but the risk is there. Lenalidomide overall probably has a less incidence of inducing neuropathy. So choosing between the two agents, Revlimid would likely be the choice over Velcade for a maintenance therapy. Okay. All right. A good question right now. And this may be for Dr. Kumar also, as you're going to talk about targeted therapy. Does the genomics of multiple myeloma, if it's been tested at diagnosis, can it change at relapse?
Yeah, certainly. I think it's a good question. So there are certain changes that we know start from right from the beginning, when the even from the monoclonal gammopathy of undetermined significance stage or MUGA stage, and those are the translocations and trisomies, essentially changes that reposition pieces of chromosomes or kind of stitch them together in the wrong place, so to speak, and also increase numbers of some chromosomes. Now, those trisomies and translocations typically don't change over time, and they remain the same during the entire disease course, and we refer to them as the primary abnormality. Then there are a set of secondary abnormalities, or things that can come up over time, and those include changes in the chromosome 1, chromosome 17, chromosome 13, typically, which can be acquired over time, or the proportion of cells that carry those changes can increase over time. In addition, those genetic changes or the point mutations that affect individual genes, they also can appear over time and an increasing proportion of the cells can have them. So those are the secondary abnormalities. So it's important for us to check for them. So even the FISH studies, we would repeat that when the myeloma relapses to make sure the patients have not developed a chromosome 1 or chromosome 17 abnormality over time. And as I just mentioned, in the future, we might also be checking for the mutations if there are specific therapies that can be informed using that.
Thank you. Okay. I'm going to address a supportive care question that comes up with kind of talking about quality of life on therapy that we touched on at the very first talk. Is diarrhea is a common side effect of myeloma therapy. Are there methods to intervene other than medications? And I would have to say, I'm assuming the person writing the question may be alluding to diarrhea related to Revlimid, because that's a very common side effect of treatment with Revlimid. And probably our most common thing we recommend is using an antidiarrheal medication such as Imodium. That doesn't necessarily always work. So it'd be a discussion with your provider team. They're alternative antidiarrheal medicines, even some that can be prescribed prescription strength. Diarrhea that's severe, point where it's impacting quality of life, causing dehydration, may also require a bit of interruption in treatment to allow the diarrhea to resolve. And there's also the possibility of some dose adjustments of medications to alleviate severe symptoms. Okay. And Dr. Bhandari or Dr. Kumar, would you like to add anything?
The one other thing that sometimes seems to help in the Revlimid-associated diarrhea is using some bile acid binding resins that have something to talk about as well.
Thank you. All right.
So one thing that was recently brought to my attention, and I had not discussed that much, was the chronic long-term use of the proton pump inhibitor that we commonly prescribe. For example, pantoprazole or omeprazole is known to increase the risk of diarrhea. So one option that was suggested to me by the gastrointestinal colleague was to switch to an H2 blocker, which is a famotidine, which is typically known to cause of its different. I have tried. Again, this is empiric. This is not evidence-based, but there might be some benefit to that approach as well.
Thank you. That was very helpful. Yes. All right. Okay, Dr. Kumar, I'm going to give you a non-genomics question. If I'm on VRD induction therapy since I'm not on a quadruplet, would daratumumab be an option for maintenance therapy? Is this being studied?
Right. So that's a good question. So there is a study that's ongoing right now that's looking at adding daratumumab to lenalidomide compared to lenalidomide alone. That is a phase 3 trial that I believe is either close to or already completed accrual at this point in time. So that will give us the definitive answer. Is there any point in adding daratumumab on top of the current standard of care, which is Revlimid? Now, can the Revlimid be replaced by daratumumab is a question that has not been asked in any of the clinical trials of where we have data at this point in time. So I think the answer to that question, easy answer to the question is only in the context of a clinical trial. I don't think we are ready to say that DARA should be part of the routine maintenance therapy.
Thank you. All right. We have a supportive care question, which I'll give to Dr. Bidari. What is the role of IVIG in myeloma therapy?
That's an interesting question. We see hypogammaglobulinemia commonly with myeloma treatment, wherein along with the involved protein that is abnormal in myeloma, which could be an IgG or an IgA, the uninvolved protein could also be suppressed with treatment, and especially if IgG becomes low with treatment, it does increase the risk of all infections like pneumonia and other infections. Routinely, it is the IVIG use is not supported, but again, on a case-by-case basis, it can be used, and we have used, and there is it is something to consider, especially if the infections are recurrent and frequent because of the low immunoglobulin levels.
Yeah, thank you. Okay, I'm going to answer a bone marrow transplant question, and the question is, if I have kidney disease from my multiple myeloma, can I also have a stem cell transplant? And the answer is yes, that even on dialysis, you can be a candidate for an autologous stem cell transplant. It is often a matter of if kidney disease is so severe, it's dialysis dependent. You're a bone marrow transplant care team coordinating with the kidney doctors at their institution to work together for your stem cell transplant to make it safe. And the melphalan chemotherapy is still administered, and it's just at lower doses. So kidney disease is so common with multiple myeloma, it is not considered a barrier to stem cell transplant. And a second transplant question, since Dr. Bidari is one of our partners in bone marrow transplant for myeloma, is what do my multiple myeloma labs need to be a candidate for stem cell transplant?
That's a very good question. We need at least what we call as a partial response from your initial level of protein. Say, for example, if you start out with an M protein on your SPEP of, say, let's say 3 grams, we need at least a 50% reduction, which would be down to, say, 1.5 grams, which is still considered a high number to do the transplant, but that is the minimum criteria that we have to use. That just reflects that you're sensitive to the chemotherapy, which also predicts that the transplant might be of benefit to you. So usually we target something called VGPR, which is called very good partial response, wherein there is a 90% or higher reduction in your myeloma protein level before we think the transplant will be really of benefit.
All right, thank you. Okay, another question regarding Revlimid. Is there, I'm a Revlimid maintenance. Is there any concern about any renal interaction with lenalidomide? I don't know if either of you have any experience other than needing dose adjustments for Revlimid with kidney disease. So I'll answer that Revlimid is safe with any forms of renal dysfunction. Just our multi-myeloma medications by renal function often just need consideration for dose adjustments, just depending on which medications they are. All right. Okay. For Dr. Bidari, in the state of a patient with relapsed refractory disease, if we've relapsed after combination therapy, is there a consideration of which drug a patient may be refractory to, and how do you decide on next line of regimen with that consideration?
Yeah, that's again a common question that we get asked. So again, it depends on what you were most recently exposed to and what you have been exposed to in the past. For example, again, in the current treatment scenario, at least in the US, we start with 3 drugs and maybe again a 4-drug regimen. And if you get a stem cell transplant and let's say you go on lenalidomide maintenance, and often the response lasts for anywhere between 3 to 5 years on post-transplant and Revlimid or lenalidomide maintenance. And if you relapse at that time, you are considered resistant to the lenalidomide. We would not use that in your next line of treatment. On the other hand, if you have been on Velcade or bortezomib maintenance and you relapsed on that, typically you would not be considered responsive to Velcade or in the next line, and we would typically avoid that. So that's how we determine the what is resistant or what is not resistant.
Thank you. All right. We've gotten a few questions related to the state of myeloma talk at the beginning. And it's a lot of questions that if I have multiple myeloma, should my family be tested also, my first degree relatives? I can't say no to that question. That we did mention that there's a higher risk of possibly having myeloma if you do have a first degree relative with myeloma, or even a higher risk of having MGUS, that monoclonal gammopathy of unknown significance, which is a precursor, sometimes a precursor state to multiple myeloma. So I think it is at minimum worthwhile, if you have a first degree relative of myeloma, mentioning that to your primary care physician or primary care team, kind of talking through any additional risk factors you may have. It is a simple blood test. You don't have to have a bone marrow biopsy to be tested. It's blood work that can be done to test for myeloma or MGUS. So it definitely should be a consideration if you do have a first degree family member. All right. Okay. Dr. Kumar, if a patient cannot have a stem cell transplant, can their survival be similar on maintenance therapy and subsequent care for relapsed refractory disease?
Yeah, so it's a very good question. I think what we have seen is with the newer therapies, for example, the daratumumab with the Revlimid and dexamethasone, the phase 3 trial, the progression, the duration for which the disease was kept under control was almost the same as in patients who are transplant eligible getting a transplant and Revlimid maintenance. So I think they are catching up in terms of the efficacy of therapy. Now, one thing that do need to be kept in mind is what we have seen is in the trials, if someone cannot get is able to get a stem cell transplant but decides not to get a stem cell transplant at any time during the course of the disease, then there might be, they probably have a decreased survival compared to the patients who actually did get the stem cell transplant. I think that is, again, myeloma is, we cannot cure the disease. We need every therapy we have available to try and control the disease for as long as we can. So if one therapy is completely discarded, then it's going to have some negative impact. However, as I've said, the patients who are ineligible for stem cell transplant, their outcomes are increasingly catching up with the patients who are eligible for stem cell transplant as long as they can get all the therapies. it finally boils down to why a patient cannot get a stem cell transplant. That might be what eventually determines the longer term outcome. Is it because of other comorbidities, or is it because somebody is older? And those are factors that do decrease the overall long-term outcomes.
Okay, thank you. And I'll address one question that quickly came in after I talked about first-degree family members getting tested is, how old should my kids be tested for multiple myeloma? Completely understand that question, but not young children. Multiple myeloma is definitely a malignancy of adults. We do see, like we mentioned, the average age of diagnosis is in the 60s. We do see, and we're talking about this in our diversity section, that by ethnicity, some races have an average diagnosis in their 40s. So first-degree relatives definitely need to be of adult age, may consider testing, especially at screening for MGUS, I would say around probably about 40 years of age. Dr. Bhandari, Dr. Kumar, would you have a different opinion?
No, I think, there was data that was presented from the ICE-MM trial at ASH last year. Clearly, if you screen a population, you will identify more people with monoclonal gammopathies, and you will also identify some people with slightly more advanced smoldering myeloma and few patients with light chain amyloid. I think what we don't know right now is using a universal screening in the patient, in the general population, really makes any difference in the long-term outcomes for these patients, meaning improving the survival. So general screening is, at this point, I think it's too premature to recommend general screening. However, as you already mentioned, the people who have at least, in general, what we are considering is people with more than one first-degree relative who has a monoclonal gammopathy or myeloma. It's reasonable to consider testing, especially after the age of 40. And in African Americans, given the threefold higher prevalence and incidence, it's certainly good idea to consider testing if you have at least one other family first-degree relative with a monoclonal gammopathy.
Okay, thank you. And another question dovetailing on this conversation is what specific test is meant by screening? And we would say that would be normal blood work. That's a CBC for blood counts, a complete metabolic panel, the CMP, so you can look at your electrolytes and kidney function. And then it's the two tests we discussed as the blood test, the serum protein electrophoresis, and then may also include a free light chain assay. Okay.
One thing I want to add is I recently had this request from a patient who was relatively had multiple members in his family who had myeloma, and unfortunately, all the other had who requested their physician insurance denied. So that is something that that can be encountered. So there's no easy way around insurance not approving a routine screening. So I don't know if that's something that you have encountered as well.
Yeah, typically, at least in the practice, I haven't encountered issues with insurance coverage, because you could order a monoclonal protein for a variety of different reasons other than just screening. So yeah, I at least haven't encountered that. I think if you're screening, I think as you already mentioned, the serum protein electrophoresis, immunofixation, free light chain, just 3 of those tests is sufficient to rule out presence of monoclonal protein in over 99% of the people, if there's one.
Thank you. Question for Dr. Kumar. You mentioned a difference in sub-Q and IV Velcade. Daratumumab is also offered by sub-Q and IV form. Are any differences in side effects by method of administration?
No, the only difference in side effect is actually a good difference in the sense that the subcutaneous is associated with less infusion reaction. And of course, you save all that time having to sit and wait in the chemo room. With the subcutaneous, it's much faster. You get it done and leave.
Thank you. And we're going to have time for answering a combination of a couple questions we've gotten about the Cure Cloud. We got a question if it's available in New York, And we appreciate that question. I have to say it's not available yet in the state of New York due to different rules regarding the return of DNA data to patients, but that's being worked on, and it's hoped that will be resolved soon. And we apparently have some international viewers because there was an ask of, is it available in other countries? Right now, it's not available outside the United States, including Alaska or Hawaii, because of the time it takes to ship a DNA sample to the testing center in Boston, and that the DNA would still be viable or live for those tests. But we really appreciate the interest in the CureCloud trial from our audience. Okay, so we're going to actually conclude this first town hall question and answer session with all of our panelists and move on to the next presentation on our agenda. And that is, we're very happy to have from Ochsner one of our patients with multiple myeloma, Ms. Yolanda Coleman, who is here to talk about her patient experience as she's been on her cancer journey of multiple myeloma here for several years.
Hello, I'm Yolanda. I'm a New Orleans resident, and I've been living with, well, I've been thriving with multiple myeloma for the past 5 years. This April will be when I was diagnosed, in September when I had my transplant. And I must say that the treatment that I received as a patient was great and has been great. I had a very I was pretty bad off when I was told that I had multiple. Well, that I was told when I was told that I had myeloma. I had 2 fractures in my neck, and I lost the ability to walk. I was physically really bad off, but the treatment that I received through the oncology department has been and was great. Never was it presented to me that I was like a hopeless case. When I was presented about being a part of the study, it was because it was told to me that the type of cancer that I had was very aggressive, and they wanted to treat it equally as aggressive. So it was always positive, always informative as well throughout the steps of my treatments. And I'm quite grateful that I was a patient at Ochsner to receive the type of treatment that I have been receiving. As I talked with Dr. Finn earlier this year, that I really feel that if I wasn't a patient of Ochsner to be a part of the study, I really don't believe that I would be where I am right now. So in so many ways, I'm so grateful to be a part of the study, the way that I was treated and have been treated as a patient in the study. So, you know, I'm doing well. I'm thriving as a person who has multiple myeloma, and I was diagnosed at the age of 44, and I've been living with it, as I said, for 5 years. So I'm 48, and I'm only progressively getting better. As I said, I was losing the ability to walk, and now I'm ambulatory, and I'm doing very well. I'm thriving in this. So.
And I'll ask a few questions, Yolanda.
Yes.
How long through the time you were having symptoms did it take to the time it was discovered it was multiple myeloma?
I believe I have been having symptoms for a couple of years, because I had anemia, and then I began to have chronic fatigue, and I had those 2 symptoms for, like I said, a few years, and it wasn't until I had a fracture that my primary care doctor told me to go over to the main campus of Ochsner and have an MRI, that it was discovered that I had, myeloma.
Right. And what was the first treatment that was offered?
The first treatment that was offered was they wanted to do. I was post surgery of post neurosurgery of my neck. They wanted to do a bone marrow biopsy to figure out exactly what it was that they were dealing with me.
Right. And when they started to talk about medications and the therapies that were going to be used, what was first offered, and what did you think about that?
Well, lenalidomide was offered, and I was fine with it. I had a little diarrhea, but that was it.
Right. Was clinical trial ever mentioned in your care?
Yes, it was. That was the main thing that was introduced in my care. Like I said, it was pretty aggressive, and they wanted to treat it aggressively. And I was introduced to, I was informed about the study, the clinical trials that they offered, and we went through the process of being tested, and I was a prime candidate, and I've been in the study since, and I've been doing pretty well with my maintenance medication as well.
Excellent. Was there any concern when a clinical trial was brought up as first treatment? Was that scary in any way?
It was not scary at all. Dr. Finn, I was in a terrible way physically. And I had never been, I had never had issues with my health. Although I am obese, I've never had any other chronic conditions. So it was like literally having a rug ripped from underneath my feet. And when I was informed about the clinical trials, it was presented in such a way where, like I said, you know, Yolanda, you have an aggressive form of this cancer, and we want to treat it aggressively. It was never like a hopeless state. It was always just treating you aggressively so you can begin to thrive in your life.
Right. And how early was stem cell transplant discussed with you?
In the beginning, when the study was introduced to me, it was the two types, the autologous, and I really can't remember the next one, the other one, because I had the autologous transplant. So yeah, and everything was explained to me in detail. Everything from the high dosage of chemo, prep first with the Velcade, those treatments that I had leading up to the stem cell transplant, hair falling out to everything will be better. You know, every detail that you would go through as far as being a patient and given a high dose of chemo, and the things that happen to your body was explained to me, and I was told, all you have to do is just not stress out, which it wasn't even a stressful environment, but everything that I was told would happen to me happened to me, and they were like, well, you know, you're going to be fine after. Your hair's going to grow back. You're going to be fine. So it was a good experience, I must say. Even though it was dealing with something that's, you know, cancer, it was a good experience. I had good experiences with my nurses. Everyone who I came in contact with through that process, it was just a great experience as a patient.
Good. Did you feel like you had a voice in your care team that your thoughts were included in the decisions as they were made?
Yes, I did. I certainly did. And one thing I also knew is that my treating physicians, they knew what was best for me. So as they would present me with the treatment, you know, it was always open end. Like, you have any questions? Are you concerned? And I had no questions or concerns. once again, the state that I was in physically, to be offered the assistance to have to regain quality of life was all that I was focused on, and that was presented to me.
I think we have a lot of people in the audience today listening where transplants, they may be pre-transplant and is being considered. What do you remember as the hardest thing about bone marrow transplant?
Being patient to stay in that hospital room.
How long was your hospital stay for your transplant?
I think it was 17 days. Was it 7? I think it was 17 days.
Mm-hmm.
And trying to explain to Dr. Finn, my day 0 was my day 1. And she was like, no. So, yeah.
And how long after transplant did it take for you to feel like you fully recovered?
Not long after. I pretty much felt pretty good. As far as the transplant, my only, I guess, issue was the physicality of walking, because I had to wear a neck brace that went down from my neck to my waist, and I was utilizing a walker at the time. So that was really the only issue that I had, was allowing my body time to heal, where I can ambulatory more independently.
Mm-hmm. And at least for us at our cancer center, we ask that family and friends as caregivers are really involved, especially in the transplant process. Who of your family helped you through your transplant as your caregiver or caregivers?
My parents. My parents and a friend of the family who I attend church with. Because I wasn't able to drive, still not able to drive. And I was able to, she was able, like I had a nice lady, a friend of the family that would bring me to the hospital or to my clinical visits, and so with my dad. So family support is extremely important, because to once be able to drive myself wherever I needed to go, and then have that taken away, that could have just been an added stressor if I would have had to, worry about getting to my visits. But it was no problem with family and friends.
Right. Your network's so important, isn't it?
Oh, it very, very important.
Right. And are you on treatment now for your myeloma, or any medications right now?
Yes, I'm on my maintenance medication of lenalidomide, Revlimid.
Yes. And do you mind sharing what side effects you may experienced and how this impacts your quality of life?
Like I said before, just a little diarrhea, and usually that's if in between the visits, if my visits are kind of spread out and I'm off the cycle, and then when I return back to the cycle, it kind of gives me a little diarrhea. But lately, it's been consecutive. So as soon as I run out, I'm at your office and I'm getting my refill, and it hasn't been any issue.
Excellent. Good. And if you met someone today that was newly diagnosed with myeloma, you now have this years of experience. What advice would you offer?
I would say to be patient with yourself, especially if you if there's a fracture in the neck. I would encourage them to be patient. That your body will be able to do, maybe not exactly what it was once able to do, but it will be able to do more than where you are right now. To just be patient with your body and follow your physician's instructions. So it's been pretty easy for me.
Mm-hmm. All right. Well, thank you. Any last words you'd like to offer about your experience?
Well, I would like, and I hope, and I'm greatly appreciative of this opportunity. And I just hope that multiple myeloma is a more known cancer prior to diagnosis, that people will be more informed of what multiple myeloma is or what the symptoms are. So it won't be like how my experience was as far as going into the ER with a fracture. You know, just so that patients can know what to look out for more and ask more questions concerning what that disease is, and because they're familiar of the signs and the symptoms.
Mm-hmm. I appreciate that. And that's a really pertinent statement here in Multiple Myeloma Awareness Month as we're doing this talk this weekend. All right.
Oh, yeah.
Thank you for sharing your experience, Yolanda.
Thank you.
Okay. Next on our agenda, as kind of dovetailing off of Yolanda's discussion of her experience, where she's mentioned she was a part of a clinical trial and even went through a stem cell transplant. We're going to broaden that discussion with that talk on precision medicine and myeloma research in its current state. Our presenter is Dr. Saji Kumar. He is presenting with us today from the Mayo Clinic in Rochester, Minnesota. We're very thankful to have him. Dr. Kumar.
Thank you, Dr. Finn. It's been really exciting presentations and certainly a lot of very good questions. And it was good to hear from Yolanda, her experience as well, which I'm sure many of you on the call can identify yourselves with. So we heard a lot about all the new drugs that are coming through and all the new combinations that we are using for treatment of newly diagnosed and relapsed multiple myeloma. Now, what I'm going to focus on is what we hope will be the next phase of myeloma therapy evolution, where we can, instead of just using the same treatment for everyone, we can individualize the treatment for a given person. And again, this is important because as you all realize, as you hear about the individual stories, that it's very different for each person with myeloma. It's the myeloma, the name multiple myeloma was not coined because of this reason, but it seems quite apt that the name really reflects what myeloma does, which is it behaves in very different or multiple different ways in different patients. So what I'm going to focus on two specific aspects in which might allow us to tailor the treatment for the individual patient. And one of them is looking at the underlying genetic abnormalities that we briefly alluded to in the Q&A session, the town hall. And the second is trying to develop new tools in order to better inform us how much treatment does a patient need and and what should be our goal of therapy. So let me start off with the whole concept of myeloma not just being one disease. Just because it has the same name doesn't mean it's going to behave similarly in everyone. It's a very heterogeneous disease. And the heterogeneity in this disease and the differences in the outcome are mostly driven by the changes in the genetic material within the myeloma cell. So while the treatments that we have used up until now has been effective and increasingly becoming more effective, it uses a one-size-fits-all approach. And it's quite possible that we are over-treating some individuals or under-treating some individuals. And maybe some patients need a different drug than the other patient next to them. Just to again highlight this particular aspect, we're talking about two different patients in the COMBA study. And this is a study that was, again, briefly mentioned in the beginning, where a large group of patients, clinical data was collected over a period of time, and also a lot of genomic studies were done on the bone marrow samples. So here we have two individuals, same age, same both locations, ISS stage 2. They both got the same treatment. And when you look at the underlying cytogenetics, they had high-risk markers, translocation 414, deletion 17p. In one person, the VRD treatment just lasted a month and the myeloma started progressing. and the other patient actually had the myeloma stay under control for more than a year and a half. So what was different between them? So the difference actually was in one of the genes called the TP53, which is often referred to as a guardian of the genome, because in the normal cell, if there is genetic damage, that cell will immediately undergo death, or the cell will be forced to die, so to speak, by the action of this particular gene. So if that gene is mutated and not functional, then the DNA damage or the genetic damage in the myeloma cell continues to accumulate over time. So a lot of the studies, particularly the studies that have been done through the COMBUS effort, has identified a series of mutations, about a dozen of them, that occur in majority of the patients with multiple myeloma at varying proportion. Now, the question is, we don't know whether this particular mutation in a given patient is the main reason why the myeloma is behaving the way it is. It may be true for some of them, and maybe in some individuals, it could be a mix of different things. Nevertheless, by targeting these common mutations, we hope that we can develop treatment strategies that are more effective than what we are using currently. So, for example, the most common mutation that we see involve genes called KRAS and NRAS, about 40%, and another 8% of them have a mutation in a gene called BRAF. These three genes are all involved in a similar, what we call a signaling pathway within the myeloma cell that protects the myeloma cell from treatment and also allows their growth. So here's an example of a patient who actually has the BRAF V600E mutation in their myeloma cells. On the left-hand side is before treatment with a specific drug called vemurafenib that targets the changes induced by this particular mutation. And you can see that after treatment, a lot of those bone lesions that are lighting up or very dark on the previous picture has disappeared in the after treatment picture. So based on this, there have been some studies done, particularly looking at targeting the pathways that are upregulated or that are activated by this particular mutation. And it was shown that some of these patients actually do get good response to the treatment. Now, another paradigm, we talked about these mutations that are often acquired over time, but there are also changes in or fundamental differences in the biology of the myeloma based on the underlying primary abnormalities we talked about. And these include the translocations. So the translocation 1114 is a situation seen in about 15 to 20% of patients with myeloma, where a piece of chromosome 11 goes and attaches itself to a piece of chromosome 14, and this in turn gives some advantages to the myeloma cell. So we and others have studied a drug called Venetoclax that is already approved in other heme malignancies, hematological cancers like CLL or chronic lymphocytic leukemia. And based on some initial studies that this drug is quite effective in patients with myeloma who have this translocation 1114, several trials have been done, again highlighting that if you add Venetoclax to the standard treatments, patients with this translocation can derive significant benefit. So it's an example of what we call a biomarker or some unique characteristics in the patient which can be matched up with a specific therapy that would give better results. Similarly, there have been the Venetoclax has been combined with other drugs to see if it can work even better, and many of these studies are ongoing at this point in time. So even though when you talk about clinical trials, a lot of the clinical trials typically follow the same fashion. You have a phase 1 study to understand the best dose, then you have a phase 2 study to understand whether the drug actually has some benefit, some preliminary signal, and then you have phase 3 trials, which are very definitive, where you compare a new drug to a standard treatment or a new combination to a standard combination to see if that is better than what we currently use in the clinic. Now, when we start talking about personalized medicine or individualized therapy based on certain characteristics, the clinical trials will have to be done in a very different way. And mostly there are two major groups of trials. One of them is called a umbrella trial or a platform trial, which we'll talk about in a second, where you have patients assigned to different arms of the trial based on the underlying genetic change or biomarker which then determines what specific drug that person would get, again, based on data supporting the use of that specific drug in the context of that specific abnormality. And then there are basket trials, which are actually agnostic to the type of cancer, but just focuses on that particular abnormality. So you could have patient with colon cancer, lung cancer, breast cancer, everything in one trial, but they all have the same genetic change in their tumor cell. Now, the umbrella trial or the platform trials is, we have a very good example in the context of myeloma. This is a trial that is done by the MMRF and the Multiple Myeloma Research Consortium called MyDrug. And the MyDrug stands for basically myeloma drug regimens using genomics, basically meaning we are trying to develop these therapies based, using their underlying or trying to target their underlying genetic abnormality. So patients with myeloma that relapses very early after the initial therapy, we do sequencing of their tumor cells, understand whether they have one of these common mutations. And if they have one of the mutations, then we assign them to a particular arm that includes a drug that we know would be effective against that particular mutation related changes. And then if after a couple of cycles, we add a standard treatment to that targeted agent, knowing that one drug alone is often insufficient to control myeloma for a long period of time. So this trial is ongoing. This is an example of a patient who had initial treatment, transplant, maintenance, progression. At the time of relapse, they got elotuzumab, pomalidomide, and dexamethasone. You just heard about that earlier on. And when the patient relapsed again, this patient actually was treated on the arm C1 because of their underlying abnormality in the RAS gene. In this particular case, 56% of the myeloma cells had this NRAS gene mutation. So this patient was treated with a targeted therapy called cobimetinib, which is a pill. And you can see that with the cobimetinib, you already start seeing the myeloma protein starting to go down. And when you add the standard treatment of Ninlaro, pomalidomide, and dexamethasone to the cobimetinib, you see that there's further decrease in the monoclonal protein to a very low level. So we know that this approach does work, and we're continuing to study different combinations, hoping that we can bring some of these to the clinic. So the main takeaway messages from the precision medicine approaches is, again, understanding the underlying disease biology, knowing what makes a tumor cell tick, so that we can actually target that particular pathway or particular genetic change using drugs that will hopefully be more efficient in getting rid of these cancer cells than just using the combinations. And again, with fully understanding that these drugs are likely to build upon the success that we have had with all these new therapies. Now, the other aspect of individualizing therapy is the whole concept of targeting or aiming for minimal residual disease negativity. Now, a lot of the testing that we do in the clinic, like the proteins that you're very familiar with, has very low sensitivity in terms of identifying whether tumor cells are left behind. So you can have a protein study that's completely negative and still have millions of myeloma cells still left behind. So there have been a lot of interest in trying to understand, can we use more sensitive tests to identify the persistent myeloma cells? So to that extent, we have developed studies that are looking for very small numbers of myeloma cells in the bone marrow after treatment. So right now, the way we define the absence of minimal residual disease is if you do one of these sensitive tests, and if you examine 100,000 cells and you don't find any myeloma cell among those 100,000 cells, then you would call this particular person as having MRD negative response. Now, in addition to looking at those myeloma cells in the bone marrow, it is also important for the protein to disappear from the blood in order for us to say that somebody is MRD negative. Now, how are we examining that bone marrow? There are two different approaches. Both have some pros and cons. One of them is using what we call a next generation sequencing, looking for, genetic markers of myeloma cells that are left behind. The other one is using a method called flow cytometry, which looks at markers on the surface of the plasma cells to identify whether there are myeloma cells left behind. They are quite comparable in terms of their ability to detect very small numbers of cells. And so when you do one of these tests and you put that in the context of the protein studies in the blood and the urine, and sometimes also PET scans, we can say somebody is MRD positive or MRD negative. If you're MRD positive, that means you have some cells still left behind after treatment. Now, why is it important? We know that if someone gets a treatment and they become MRD negative, they are going to do much better in terms of keeping the disease under control for longer periods of time compared to somebody else who got the same treatment but still is MRD positive at the end of the treatment. So so it's a good way. So it has a prognostic influence. So it tells you how the myeloma is going to behave. It also can be used to compare different treatments to say, is one treatment more effective in eradicating the myeloma cells? And the other piece which is going to be important for us going forward is to see whether we can use this MRD testing to decide when to stop treatment, when to start treatment, how long does the treatment has to be given, and whether we need to give more treatment than what the patient is currently getting. So all these different approaches, everything is trying to define, is that MRD test a tool in the clinic that you can base your treatment on? So there are some studies ongoing, like with this master trial that was presented where patients had their treatment stopped if they had a couple of MRD tests that were negative. There are studies that are ongoing that are looking at patients after a defined time of therapy. If they are still MRD positive, does it help us to give some additional treatments? So those kind of studies are ongoing. The disadvantage of many of this MRD testing right now is that it requires a bone marrow. So we are all constantly trying to identify testing methods that can be done on the blood. So there is mass spectrometry is another approach for looking for very, very low levels of protein in the blood. It is becoming standard, and hopefully at some point in time, this will allow us to do the MRD assessment in a more targeted fashion. I don't think it will replace the bone marrow, but it will allow us to do the bone marrow biopsy in a more selective manner. So I think the minimal residual disease assessment, you hear about that all the time. It's an important goal in multiple myeloma. Getting there does mean better outcome. What we don't know right now is if we don't get there, do we need to change treatment? Do we need to intensify the treatment to try and influence the course of the disease? So that's currently being explored in the context of clinical trials. So with that, I'll stop and thank you for attention.
Thank you, Dr. Kumar. We're going to have a great discussion in our next Q&A as we see questions are actually coming in regarding this precision medicine presentation and even regarding Yolanda's patient experience of myeloma. Our final formal presentation is going to be a short discussion on healthcare disparities in multiple myeloma. And this is a talk about the differences in multiple myeloma and how it presents by different ethnicities and how hopefully we can do our best and make improvements in providing equal care to all of our patients with multiple myeloma to achieve similar outcomes for everyone, similar good outcomes for everyone. So multiple myeloma, as we mentioned in the first part of our talk today, can differ in some degree by patients who are Black, of Black ethnicity and those of other races. We've seen by our first presentation that myeloma has an increased prevalence and an increased death rate in patients who are Black that is 2 times that of our white patients. That our patients with myeloma that are older often have an increased incidence of the myeloma precursor condition called MGUS, but also that we diagnose Black patients at a younger age, average age in your 40s rather than in the 60s for other races. There's increased incidence of comorbidities at the time of diagnosis. And I have to say, sometimes those comorbidities can delay diagnosis of myeloma while trying to identify why those comorbidities exist. An example of that is kidney disease is not only a byproduct of multiple myeloma, but may exist for other reasons, such as diabetes or high blood pressure. And undergoing the investigation of the cause of kidney disease, if other comorbidities are present, may delay the finding of multiple myeloma. There's an increased incidence of a myeloma-defining event. A myeloma-defining event is one that affects your organs. Those organs that we mentioned in the beginning: hypercalcemia, renal dysfunction, anemia requiring dialysis, very serious findings that are important, and will often bring a patient to their doctor's office, and sometimes more often not the emergency room, because you feel so bad. And it's difficult to receive a cancer diagnosis at any phase, but especially when you're presenting so ill. A difference that we find against comparison to other ethnicities is, while Yolanda mentioned that she actually had a fracture as her presenting symptoms, that's actually less common compared to other races. Molecular and genetic factors can be different. We've gotten many questions about the P53 or deletion 17p chromosome and its seriousness. It's a high-risk prognostic factor in multiple myeloma. The presence of deletion 17p is seen less frequently in Black patients. The frequency of other mutations and their significance is currently not known. That is one reason to consider contributing information to the Cure Cloud, the Multiple Myeloma Research Foundation, so that we start getting large volumes of information about multiple myeloma, including its molecular and genetic factors from all ethnicities. And one thing we need to make an impact on is myeloma treating physicians and your care team is to make sure there's equal offering of treatment to everyone. And there have been studies that have shown that there has been lower utilization of standard of care, meaning triplet or quadruplet therapy, and significantly lower incidence of stem cell transplants for patients who are Black. The risk of myeloma over time increases. We included this slide to show that there is this age difference between the average age of diagnosis we see here is in the 60s for the purple line of triangles compared to a very young age in our Black patients in their 40s. And I have to mention we've had several audience members who have mentioned in the chat that they were even in their 20s and 30s, well, no ethnicities, but in their 20s and 30s at the time of their diagnosis. There are disparities in care that we need to address, and this is a good time to bring it up so we can fix it. Several studies have shown that the use of standard therapy tends to be lower in our Black patients. We see triplet therapy is considered the current standard of care in multiple myeloma. I think there's research and conversation ongoing of whether quadruplet therapy or using 4 drugs would be standard of care. We see there's a 10 to 20% difference in its utilization by race. We also see there's a 10% difference in the offering of stem cell transplantation by race also. Reason we need to correct this is we see by clinical research of population-based studies that if we do offer the same therapy to everyone, we can see the same outcomes in everyone. We see that outcomes of Black patients who are the same as white patients, that they are offered participation in clinical trials, and the response rates and survival of Black and white patients are similar after stem cell transplant in an equal access system, which all of our cancer systems need to be equal access. We have audience members from really all over the world. We have some international audience members, but also nationwide. And I practice here in Louisiana, and that's why this slide is important to me, but I'm sure it's of interest to everyone listening. You can see that the incident rates can differ by state. We see a high incidence of multiple myeloma here in the Gulf South. You can see it by the darker orange-red colors and even the deep maroon color of Georgia. And we see that death rates also differ by location, with exceedingly high rates here in the Gulf South also. What are the reasons far disparities of outcomes of patients who are of Black race compared to other ethnicities. Things that have been studied and that are shown in research on this topic is that in areas there may be less access to cancer screening services. We mentioned that there aren't necessarily age recommended cancer screening for multiple myeloma, but there definitely are blood tests that can be performed if risk factors are there. We wish it wasn't true, but structural racism can exist in communities, and I would hope not in a healthcare system, but sometimes unintended bias is present and should be addressed actively. There may be social determinants of health that can impact comorbidities and comorbid conditions that may be present that may impact available treatment and even possibly delay diagnosis of multiple myeloma. There's a shortage of African-American physicians, and there's also a lack of familiarity with Black economic and social conditions that may impact access to healthcare and access to cancer centers with expertise in multiple myeloma. We mentioned that comorbid conditions can delay the onset of diagnosis, and therefore disease severity may be increased at the time of diagnosis. And something we can fix as cancer centers is through education of each other and through physicians that may be first point of contact with patients' myeloma is to start equalizing the access to the same level of care and same level of treatment that there is for patients of other ethnicities. Some key points. Despite disparities in the incidence and the outcomes of multiple myeloma among Black patients, evidence suggests that if we acknowledge these disparities and work to address them, they can actually be overcome. We need to ensure there's equal access to appropriate therapy that is standard of care, equal access to clinical trial options, and equal access to stem cell transplant for our Black patients. We need increased awareness of these disparities and their solutions to their patients, physicians, and our communities, and that's going to be through acknowledgement that this needs to be addressed. Okay, so we're going to include all of our panelists. We're going to move now into our second town hall question and answer session. We have received over 200 questions, and we're going to work through as many as we can through the next half hour. And I'm going to start with an easy one, hopefully for Dr. Bhandari. Actually, it came up, a few audience members, they were very interested when we were having the discussion of diarrhea, and you mentioned switching the proton pump inhibitor to an alternative drug class or drug. If you could mention again that discussion and what the alternative drug was.
So again, this is, I have to clarify, this is not backed by any strong evidence. So there is that caveat. But again, a known side effect of long-term use of the proton pump inhibitor, which is usually omeprazole or pantoprazole, which we commonly prescribe with steroids. One common side effect is diarrhea because it alters the acid in the stomach and it works, and that has been a known side effect. So there are some case reports that switching to the H2 blockers, which is commonly famotidine, might overcome this issue. But again, you have to talk to your doctors whether that is a feasible option. One thing that I had to I wanted to mention before was there are also some case reports that some patients who are lactose intolerant can also have excessive diarrhea with Revlimid, because Revlimid in the process of manufacturing has a small amount of lactose in it. Again, that is something that you can consider, and there are enzymes that are available over the counter that can overcome. If you have lactose intolerance and you have diarrhea because of that small amount of lactose in Revlimid, that might be something to consider. Again, this has been reported on in some case reports.
Thank you. I'm learning today, listening. All right. We have a audience question for Yolanda. Throughout your care, how often does your care team sit down and explain your lab results with you?
Every time I have an appointment, labs are drawn, and my labs are explained to me monthly.
Okay, thank you.
You're welcome.
We have a question. Let me direct this to Dr. Kumar. Several patients have brought this up. Is myeloma always a blood finding? I have several questions about patients who have solitary plasmacytomas, and a question is, does that mean they also have multiple myeloma?
Yeah, it's a very important question. I think in general, most patients, about 85% of the patients with multiple myeloma will make an M spike that you can detect on, the routine testing. You talk about the electrophoresis. About 15%, or more like 12% of the patients may only secrete a kappa or a lambda light chain, free light chain that can sometimes escape the electrophoresis testing, but can be picked up on the serum-free light chain assay. And there are about 2 to 3% of patients whom we call as non-secretory myeloma, where there is really the myeloma cells does not secrete any protein at all. And those are the patients where in order to see if the treatment's working, we may have to do scans like a PET scan or do bone marrow biopsies to see if the plasma cells or the myeloma cells are decreasing in amount. Now, this whole spectrum of disease has multiple different stages or so to speak. So you have the precursor conditions we talked about before, like the monoclonal gammopathy of undetermined significance and smoldering myeloma. And then there are other conditions called plasmacytomas, where solitary plasmacytomas, which can be, which may not be associated with any increased plasma cells in the bone marrow. And then there are patients who have the solitary plasmacytoma, who also have very low levels of myeloma cells in the bone marrow, insufficient to make the diagnosis of multiple myeloma. And the plasmacytomas typically are essentially just collection of these abnormal plasma cells that can affect a bone or just by the side of the bone or any soft tissue, like in the muscles or any given organ. So you have to make the distinction between something that's very isolated, like a plasmacytoma, and also something which is more widespread, involving most of the bone marrow, like multiple myeloma.
Thank you. I have a question for Dr. Bhandari. How does one know if they have relapsed or refractory multiple myeloma? Is it through blood tests?
Yes, the concept of relapse is very similar to the initial diagnosis. Again, if your initial myeloma was diagnosed based on the blood test, so you are most likely the relapse also will be most likely diagnosed based on the same or similar blood test. And again, like Kumar just mentioned, the M protein or M spike on the myeloma blood test is very important. And there is a cutoff to say what is considered as relapse. And based on the lowest number on that M protein, if it has to increase at least half a gram or 500 milligrams to call it that you have relapsed or progressed. So that is a commonly used definition to call that you are relapsing.
Thank you. And Dr. Kumar, just as you finished talking about plasmacytomas, we have a question. If a plasmacytoma is present but has no symptoms, does it need treatment?
Yeah, that's a good question. The plasmacytomas, there's a risk of progression to multiple myeloma in patients with plasmacytoma, and typically, if the plasmacytoma affects the bone, there is an increased risk compared to plasmacytoma not affecting the bone. And also, when you have plasmacytomas with bone marrow involvement, there is an increased risk as well. Now, the plasmacytoma, that's a good question. I mean, most of the time, the plasmacytoma would have gotten detected because there are some symptoms in the first place, which prompted the imaging studies to have been done. So it's relatively uncommon that you will end up finding a plasmacytoma that's isolated, asymptomatic, and was picked up with the course of routine imaging done for something else. I would say if it's an isolated plasmacytoma, I would still consider radiating it because we know it's going to grow without therapy. And as it grows, it can cause problems.
Thank you. A question for Yolanda. When you were told of your diagnosis of multiple myeloma, how long did it take for you to comprehend what that meant?
It took a while because I had never heard of multiple myeloma. So I've heard of other cancers and I was familiar with other cancers. So to find out that I had multiple myeloma was really a shock. Because and at that time, that cancer, that word never even existed to me. So it was a while to really understand it. And as far as how it affects your body as well, how it affects my body.
Mm-hmm. And there's a little bit of a second part to this question. When did you feel comfortable to ask pertinent questions? And the questions alluding to, did you feel when your care team discussed your myeloma with you that information was provided all of a sudden and too much at once?
Well, it was a lot of information. I didn't feel like it was too much at once because as I was going through the process of the treatments, everything would be explained to me, and I also had a patient pamphlet, like it's the booklet that was provided from the oncology department that explained everything concerning what multiple myeloma is and the autologous transplant. So what we were working towards. So I had the information in hand, and it was a lot to read and a lot to understand, but just being treated by my physician, it was the level of comfort and security that I was provided. It was easy.
Mm-hmm. Thank you for that. Now I have a question for Dr. Bhandari. It dovetails off the discussion of plasmacytomas, but it becomes a relapse refractory question. How does someone with non-secretory multiple myeloma or plasmacytomas know if they have relapse or refractory disease?
Again, that's a very good question. So the only way is, again, through a bone marrow biopsy or through imaging, which could be a PET scan or an MRI or a CT scan, which shows there could be new, say, bone spots or other new cancers where myeloma, plasmacytoma, say, in your lining around the lung. For example, I have a recent patient who developed plasmacytoma that was initially in her lower back, and now it progressed on imaging on PET scan around her lungs. So that is the only way, and the bone marrow biopsy might or might not show that you have more disease. So you might need both bone marrow biopsy and the imaging studies to know that.
Thank you. I have a question for Dr. Kumar about your presentation. If treatment goal is negative minimal residual disease, is there a point to doing a stem cell transplant if M protein is still detectable?
So the use of autologous stem cell transplant right now is not dependent on whether the patient's MRD negative or not. And we don't have any clinical trials that have shown that if you're MRD negative, that you don't need a stem cell transplant. I think all our current approaches are based on a defined set of treatment given for a period of time, and that gives us the outcomes that we see from these clinical trials. Now, whether we can decrease that the duration of the therapy because somebody got MRD negativity much earlier, or whether we need to give more treatment than originally planned because they continue to be MRD positive, is something that has to be actually studied in a clinical trial. We can't just assume that is the case, because and there are patients who stay MRD positive and their myeloma stays under control for years. And there are people who become MRD negative and the myeloma comes back within 6 months. So it's not a absolute black and white thing. And I think a lot of things other than the MRD status, including the disease biology, plays an important role. So we are not at a point where we can change therapy just based on MRD status alone.
Thank you. And I have another precision medicine question. There are a few very similar ones are coming in. What is the role of Venetoclax, and does it depend on genomics? And there's questions, should it be used for 11-14 translocation or 14-16 translocation?
Yeah, so the Venetoclax activity, we know it's best used in patients with 11-14 translocation. Those are the patients who achieve the maximum benefit of that drug. Now, the 11-14 translocation is only present in about 20% of patients. But there's another 40% of patients who have high expression of BCL2. It's a protein that the Venetoclax targets. And those patients also appear to benefit from the use of Venetoclax. However, we don't have an assay in the clinic today that can be reliably used to identify the BCL2 level in the tumor cells in all patients. There's work ongoing trying to develop such an assay. And once that becomes available, we can hopefully broaden the use of Venetoclax to include those people as well.
Thank you. A quick question for Dr. Bhandari. Should Revlimid be included for all patients after stem cell transplant? And how long should someone be on Revlimid as maintenance therapy?
Yes. No, the answer is it depends on, again, the initial risk stratification of your myeloma. So if you are classified as a standard risk, which by definition means that you did not have 17p alteration or a 414 or a 1q alteration or a gain or a 1420 alteration. If you did not have all these alterations, then you could be eligible for Revlimid maintenance, which means because you are the standard risk disease. If you, on the other hand, if you had high risk disease, which could be one or more of the above mentioned alterations, then the effect of Revlimid, the benefit with Revlimid is not as good as when it is used in combination with Velcade or bortezomib, or bortezomib and alone. So again, depends on the risk of your myeloma diagnosis. And as to the second part of the question, initially, again, if you look at the European studies, they all recommended 2 years of maintenance with Revlimid. But in the US, it is used until progression or until intolerance. So that means there is no time limit for the use of Revlimid maintenance.
Thank you. We have a question for Yolanda. During your diagnosis, or even now, do you access a support group or any regular information online? And if so, how is this helpful?
No support group, and online, no. I prefer to leave the information online alone. But I did, one thing I did do was contact MMRF and sign up with them for the different seminars that they have with multiple myeloma. So that's really the only thing that I do outside of my physician.
Thank you. We have another minimal residual disease question for Dr. Kumar. Is there utility for MRD testing after transplant? How may it be used?
So right now we can do the MRD testing after transplant, and a lot of institutions do that routinely. If you are MRD negative, we know that the average duration the myeloma will take to come back is longer compared to if you are MRD positive. But the maintenance therapy that you give after the stem cell transplant would essentially remain the same at this point, which is just as was mentioned with the last question, Revlimid alone for standard risk patients and 2 drug combinations for patients with high-risk disease. Now, there are clinical trials that are looking at whether additional treatment before going to maintenance what we call consolidation would be beneficial for patients who are still MRD positive. And those studies, we need to get the results of those studies before routinely doing that for everyone.
Thank you. A question for Dr. Bhandari. Is there a difference between the imaging test available, PET, MR, or CT scan, that is best to detect relapse?
No, there is no difference in the terms of the imaging modality. They are all considered equivalent. It depends on the center expertise, and also in general, MRIs are considered to be most sensitive to detect very small changes, but overall they're all comparable. Again, it depends on how comfortable the imaging center or the each center is in identifying these spots on your bones or soft tissues. It also, and we've all experienced the issues with getting the approvals for PET scans from the insurance. So often that might be a limiting factor when we, as to which imaging modality is ordered and approved at short notice. It is possibly much easier to get approval for an MRI rather than PET scan based on the insurance.
Thank you. Okay, a few questions that are asking a bit about minimal residual disease testing. That is this testing for presence of plasma cells or genetic factors of multiple myeloma?
Yeah, the minimal residual disease testing is to identify if there are any myeloma cells left behind in the bone marrow. There are two different ways we can do this. One of them is, as I mentioned, flow cytometry, which is basically we take the bone marrow aspirate and pass all those cells through the flow cytometer machine, and where you have antibodies looking for a variety of different markers on the surface of the myeloma cell. So by using a combination of different markers, we can identify which are the abnormal myeloma cells or the abnormal plasma cells compared to normal plasma cells and other cells. So that is one way. The second way is to do what we call the next generation sequencing. And that is looking for a specific genetic sequence that is unique to the myeloma cell. So you can think about it as a barcode that is there in the myeloma cell. And using that approach, we can detect up to 1 in 10 million cells can be identified in a reliable manner using the next generation sequencing approach. So we are looking for the abnormal myeloma cells.
Thank you. I'm going to ask this question for Dr. Bhandari as one of our autologous stem cell transplanters. I get lots of individual questions about comorbidities that may preclude a transplant. So I ask you to discuss during a transplant evaluation, what health findings may exclude someone as a candidate for stem cell transplant.
So there are, so if you are considered for an autologous stem cell transplant, typically you go through a series of evaluations. For example, we need a recent colonoscopy, we need a recent pap smear if you are a female patient, a recent mammogram, and abnormal findings, for example, in any of these evaluations. And if you do have an active cancer, let's say a breast cancer that was found on a mammogram and a subsequent biopsy, or a colon cancer that was found on a colonoscopy, and any active cancer will possibly exclude you from a stem cell transplant. And we typically wait for up to 5 years after your last unrelated cancer before you can be cleared for a stem cell transplant. Other things that can come in the way of a transplant is also, say, your lung function and your heart function. If your heart is not functioning very well and your lung has a lot of, say, PD, or an emphysema that precludes you from a safe transplant, those could be other considerations that can come in the way. Or if you have an active infection that cannot be safely treated before transplant, and often we get the infectious disease doctors to weigh in, and if they feel that the transplant will put you at an extra risk in terms of infection after the transplant, that might be another barrier. And so these are some of the medical considerations that we commonly look at.
Okay, and a little bit of a follow-up question, because I'm getting this from several audience members. Is age a limit to stem cell transplant, or is it more overall health?
It is more of overall health. Age is increasingly less of a factor, but most centers, including ours, have as a cutoff of 75 years as the upper limit. But again, there are centers which are doing it up until 80 that I know of. So it's more of a functional status, more of what we call as a biologic age rather than the chronologic age that matters.
Okay. Question for Dr. Kumar. When considering clinical trials that may be offered, should we be worried that placebo may be one of the arms of the clinical trial?
Yeah, I know it's often a misconception about the use of placebo. So one thing to keep in mind when you talk about clinical trials, the question always is the experimental treatment, whatever it might be, better than the standard of care treatment? So there are very few situations where if some kind of therapy is the standard of care, just a placebo alone will not be given. Most of the use of placebo in the setting of clinical trials would be to mask who is actually getting the treatment so that you get a more accurate assessment of the impact of therapy. So it'll be a standard of care therapy, either with placebo or with this experimental drug used in combination is the typical setting. So never worry that someone's going to give you a placebo when you actually need a treatment for the disease. That never happens.
Thank you. I've gotten a few very similar questions for Yolanda. After your stem cell transplant, how long did it take for you to feel like you were living your life again?
Once again, it was my physical disability that kind of was my issue. Because after the stem cell transplant, I was fine. I felt great. But it was allowing my body to get to a point where I can, walk around without a neck brace that went down to my waist, and utilizing a walker. And that took time. And I had to be patient with my body healing physically. So, and I'll say up until recently, I feel more normal now than I did. And that's because of my physical ability than I did right after. But right after I felt good, but I still had an issue with my limit physical ability.
Mm-hmm. Thank you. I'm also getting a cluster of very similar questions for Dr. Kumar. Are there any imaging tests that can identify minimal residual disease?
So imaging studies alone will not be sufficient to call somebody's MRD negative. So the way we have defined MRD negativity is that we cannot detect evidence of myeloma in areas where we would typically see them. Right? So in the blood, the M spike has to completely go away with very sensitive testing. Right now we use immunofixation, but in the future it's going to be a mass spec-based testing, which is quite sensitive. We want to make sure the myeloma is gone away from the bone marrow, at least to the limit that we can detect it. For that, we would use the bone marrow MRD testing with the flow cytometry or NGS, as we talked about. And the third place where we can find myeloma is outside the bone marrow. In the soft tissue, we talked about the plasmacytomas. which can occur in outside of the bone itself. And so the imaging study, either PET scan or an MRI, will allow us to examine if there's any plasmacytoma that's left behind. So if we can demonstrate that there is no evidence of myeloma in these three spots or these three areas, that's when we can say somebody is MRD negative. So it is a combination of three different approaches that gives you that result of MRD negativity, so to speak.
Thank you. Okay. Actually, have a cluster of very similar questions I'm going to address with Dr. Bhandari. For light chain only multiple myeloma and relapse, should there be any different considerations for treatment options in relapse refractory state?
No, I do not think there is any different treatment approaches, although again, light chain disease can sometimes affect the kidneys more than other types of myeloma, so that might impact what treatment or what chemotherapy options you can get. But otherwise, overall approach is very similar as the non-light chain myeloma.
Thank you. And also a few similar questions about minimal residual disease testing, very hot topic. Should MRD be tested between each line of myeloma therapy?
So the line of myeloma therapy, again, I think, when you talk about one line, a second line of therapy, that means the first line of therapy has stopped working. That means there is clear evidence that the myeloma has come back, and there is really no role for MRD testing per se, before you go to a different line of therapy, because the relapse is going to be obvious. The MRD testing is valuable at the point, or relevant at the point, where the treatment appears to have had the maximum benefit for that particular line of therapy. So it's more of trying to rule out is there any myeloma that is detectable, versus trying to quantitate how much of myeloma is there in the beginning of treatment.
Thank you. I have a question for Dr. Bhandari. If Revlimid is used multiple times with initial diagnosis and in combinations for relapse refractory disease, I've heard that there is a concern for development of secondary cancers. Can you discuss?
Yes, the immunomodulator drugs, which are Revlimid and Pomalyst or pomalidomide, they have been linked to second unrelated cancers, again, which could be lung or colon or breast. So again, the duration and the longer you have been exposed to does seem to increase the risk of these second unrelated cancers. But again, the data are also a little bit confounded by the use of other treatments. For example, this risk has been found to be increased in those patients who got high-dose chemotherapy for the purpose of stem cell transplant. So how much of that additional risk of second cancers was because of say, for example, the DNA damaging drug like high-dose melphalan versus purely because of the Revlimid use on a prolonged basis is not clear, but there is certainly a higher risk that is being found with the longer duration of use of these drugs.
Thank you. All right. Question for Yolanda. And I guess is about your social network. As we know, a cancer diagnosis doesn't just affect a patient, but your whole social group. Did your parents as caregivers have resources to help you through your transplant or even now your diagnosis of multiple myeloma?
Like financial resources?
I think more as like the support group question. Did your parents reach out to anyone for information about myeloma or for ways of how to help you?
Well, oftentimes my parents, both or one, would accompany me to my appointments. So they had the ability to ask questions of my treating physician. And so, we just kind of went from there. And like whatever the need was with me, they were there to assist. And I mean, really, it really wasn't, when I think about it, as far as like my treatment and my care, it really wasn't bad at all. It was the natural support that I had from my parents was great. And like I said, they were oftentimes there. So if they had questions of the doctor concerning my my treatment or concerning just the levels of safety that they had to take towards assisting me, they had access to my physician to ask.
Thank you. And we're going to address a question as we ended our talk on disparities, our presentations on disparities. And the question is, what is OxyHer, the Ochsner Xavier Institute for Health Equity and Research? How is it involved in Multimyeloma Research Foundation and this event? And I'm going to answer this because I think it's information that other communities can use. OxyHer is a partnership between Ochsner Health and Xavier University here in Louisiana. And through this partnership, there's a commitment to improve the overall health, not just in regards to myeloma, but many issues in health disparities, but to improve the overall health in our community, to reduce health inequities. One way we did that is we had an OxyHer presentation in our community just last month about multiple myeloma in our community. Its intent is to help develop innovative healthcare delivery models and to model equitable care for all patients. And through Ochsner, OxyHer has partnered with the Multimyeloma Research Foundation, not only to help promote this event, but to promote the Cure Cloud through the Multimyeloma Research Foundation for all of our patients here in Louisiana, because Ochsner is not just a healthcare system here in New Orleans. We actually have cancer centers and health institutions all across our state, so that the information about myeloma that's available to patients and to researchers reflect the patients who have multiple myeloma. And that's one way we're working to address health inequities and disparities, and maybe a model for others. Okay. So we've concluded, it's 12:55, so we've concluded the section of our last town hall Q&A. Apologize to those who I didn't get to questions to. Having over 200, I try to collate them in topics so that a large number of your questions are answered. But on behalf of all of our panelists and myself, we're really happy to be able to provide this information today to everyone in attendance. And next, we have some information from the Multimyeloma Research Foundation about how you can access these slides. One of the questions we had, is this being recorded? Will it be available later? I can answer that, yes. But I'm gonna pass the baton now back to Mary to give you a little more information how you can access resources through the Multiple Myeloma Research Foundation after this event.
How many times can you say multiple myeloma in one presentation and not stumble over it, right? That's good. Okay, so thank you so much, Dr. Finn. Thanks everyone for attending. This is all the time we have today for questions. I'd like to thank everyone for attending. Thank you for all the questions that you asked throughout the summit. I also like to thank all of our speakers, Dr. Laura Finn, Dr. Ambuga Badari, Dr. Shaji Kumar, and of course, Yolanda, for their time and their contributions. I would like to thank Dr. Finn for talking about our collaboration between the Ochsner Health System and the Multiple Myeloma Research Foundation. This is one of several collaborations that the MMRF is initiating with healthcare systems across the country for enrollment into our Cure Cloud study. And as Dr. Finn mentioned, the reason that we are doing this is that we are very intent on having high representation of Black patients in the Cure Cloud study, at least 22% Black patients in the Cure Cloud study, so we can ensure that the new therapies and potential cures for multiple myeloma that may be found through the Cure Cloud study study and all the data that's been collected in the CureCloud study will be as equally effective for Black patients as for all other patients. Okay, I'd like to acknowledge and thank our sponsors again: AbbVie, Adaptive Biotechnologies, Amgen, Bristol Myers Squibb, Cure, Genentech, GlaxoSmithKline, Janssen, Karyopharm Therapeutics, Novartis, Oncopeptides, Pfizer, Regeneron, Sanofi, and Takeda. So I'm going to run through some of the educational resources that we have at the MMRF. So here we have a presentation of one of our high impact topic videos. If you'd like to learn more about some topics in multiple myeloma and have some additional information, we have 8 of these videos on our website and a number of other educational resources on our website. We have recordings of all of our educational events on our website, and you can just go to www.themmrf.org. Visit the resources tab and you'll see many of the resources that we have under the educational programs button. We do have a number of other educational events planned in the upcoming months. We have a hybrid patient summit coming up with the folks in Atlanta at Emory University. That's going to be on Saturday, April 23rd. So stay tuned for that. And also we'll have a number of other resources listed on our website very soon, because we're making a lot of plans for a lot of things coming up in 2022. So I wanted to make sure that I specifically mention our Patient Navigation Center. Our Patient Navigation Center is staffed by oncology professionals, and I know that we had many questions today, well over 200, and not everyone's question was answered. So I encourage anyone who had a question that was not answered and they are still looking for the answer for it to please do not hesitate to contact our Patient Navigation Center. They can be reached by telephone at 888-841-6673, or also by email at patientnavigator@themmrf.org. And that information is here on your screen. So please do not hesitate to give our patient navigators a call and talk to them about any questions you have or any resources you might need. Another resource that we have available is our Myeloma Mentors program. So this program is a phone-based program where patients and caregivers can talk to trained mentor patients and caregivers. It's phone-based. It gives an opportunity for patients and caregivers to talk one-on-one with a trained individual to discuss their patient journeys and their experiences. So if you're interested in talking to one of our myeloma mentors, either if you're a patient who's interested in talking to another patient or a caregiver interested in talking to another caregiver, contact the Patient Navigation Center at the phone number you see there on your screen, and you can go through them to be connected to a myeloma mentor and just discuss patient experiences. As many of you may know, we also have a number of events for our Team for Cures. So we have outdoor 5K events, we have marathons and independent events ongoing. So you can find an event to join at the website that you see there on your screen. These are really fun events. They're out, many of them are outside. You get to meet many other patients in the myeloma community. So I really recommend that if you're interested in and you don't have to run, you can just go and walk and just get out there and just meet other folks in your community and have a great time. So I hope everyone found this virtual meeting informative, and I hope everyone took the opportunity to visit the exhibit hall and see all of the materials that are available to you in the exhibit hall booths. The good news is that if you weren't able to go to all of the materials that we have right now, you can go onto our website once we get everything posted at any time to access the exhibit hall, and all of the materials will still be there. So you can feel free to go back to the site at any time. So besides the exhibit hall, we'll also be posting on our website the slides from today's meeting and also a recording of today's patient summit. And that will all be available on our website within the next few days. In just a moment, you will be directed to complete an online evaluation of this program. We really appreciate it if you would share your thoughts with us of what you thought of our program, and this really helps us make our programs the best that they can be. Thanks again, everyone, for joining us today, and please enjoy the rest of your day. This concludes today's Patient Summit.